Yeah, are we live?
I think so.
Yeah, now we're live.
Yeah. Uh, a very good evening to all the esteemed faculty members and the delegates who have joined us today for the 231st edition of the Happy Learning Masterclass webinar series in association with Belgaum, Chitradurg, Mandya, Raichur, Tumkur, and Vijayapura districts. These webinars are the brainchild of none other than Dr. MC Patel, sir, who has been persistently doing it since the time of COVID. He had started these webinars in view of sharing academic knowledge so that all of us at the convenience of our homes can learn new things and perspectives about very common topics and OBGYN. Let us invoke the blessings of Lord Almighty. Can we have the inauguration slide, Rakesh, please?
Prayer slide.
Yep, it's audible. The inauguration one only, yeah. Thank you. It is my proud privilege to introduce to you our program director, Dr. MC Patel, sir. Sir has been the past vice president of FOXY, the chairperson of the Medical Legal and Ethics Committee of FOXY, president of the IMA Ahmedabad and the Ahmedabad OBGYN Society. Sir is also an active Lions member participating in the camps in the Northeast since the last 33 years, free of cost every year. Sir is following all the academic programs every week by week. We have more than 10,000 OBGYs who have joined us today in this initiative. Sir, it is an honor to be the coordinator for your program, and we invite you for your welcome address.
Thank you, Dr. Monica. It gives me immense pleasure to welcome you all to this 231st episode of Happy Learning Masterclass web series. And as mentioned, joining society Belgaum, Chitradurga, Mandya, Raichur, Tumkur, and Vijayapura. I welcome Dr. Shobna Patel, madam. She has kindly consented to be chief guest to bless the webinar. She is always with us in any of our academic activity, and madam had been faculty in past also in the same series. So welcome, madam, for sparing time for us to bless the webinar. I also welcome Dr. M.B. Ballard and Dr. Vidya Thubi and Dr. Durgadas Asrana. They all have kindly consented to be guest of honor to bless the webinar. Of course, they all are with me in any of my academic activity. Welcome, all of you. I welcome learned chairpersons, Dr. Rajeshwari Patil madam from Tumkur, Dr. Sailja from Vijayapura, and Dr. Lata madam from Chitradurga. They are going to chair very interesting session delivered by Dr. Jeevan Reddy from Tumkur. I also welcome one more set of chairperson, Dr. Manohar from Mandya, Dr. Rangnath from Raichur. They are also going to chair one more interesting session in this series, and which is going to be delivered by Dr. Megha Kamlapurkar. I also welcome one more set of chairperson, Dr. Abhijit Deshpande from Belgaum, Dr. Raju Giradi from Raichur, and Dr. Somaya Firdos Patel madam from Belgaum, and they are going to chair a session which is delivered by me only, IUFD, Aftermath, and Beyond. I also welcome two learned moderator, Dr. Rama Devi Vani Madam and Dr. Sri Devi Medgul Madam. They are going to moderate very interesting panel on prevention of stillbirth. And to be expert in that very panel, there are two important persons, Dr. Neelam Agarwal Madam from Chandigarh and Dr. Tamkin Khan Madam from Aligarh. Neelam Madam is founder president of Stillbirth Society of India, and Dr. Tamkin Khan Madam is founder secretary of Stillbirth Society of India, and they are going to put their inputs as an expert during panel discussion. I also welcome all the learned panelists, Dr. Suguna Kumar Vira from Vijayapura, Dr. Saeda Amrin from Vijayapura, Dr. Swetha from Mandya, Dr. Rachna Jeti from Tumkur, Dr. Sailja MN from Tumkur, and Dr. Abhinetri Patil from Raichur. And I also welcome my own team, Dr. Monica Omardan, she is convener for this series since long, Dr. Monica Gupta, Dr. Nivedita Datta, Dr. Deepika Logani, Dr. Satabdi De, and Dr. Megha Kamlapur. They all are coordinator in this series. I also welcome all the president and secretary of joining society, Belgaum, Chitradurga, Mandya, Raichur, Tumkur, and Vijayapura. And I also welcome all the learned delegates who have joined this webinar. Just mentioned by Dr. Monica, in era of COVID, when I started this series, I started with 4 friends, and now I am happy to announce that this is 8,000 plus member family as far as Happy Learning Masterclass web series is concerned. At that time, my goal was to meet our Foxian friends on virtual ground and to say hello and to discuss focus topic, because at that time physical meetings were not possible. But even after this COVID era is over, we continued with this series to discuss focus topic. Ultimate goal was to be helpful to our Foxian friends to deal with their problem in their day-to-day life. And ultimate goal is to check maternal mortality and infant mortality, because we are given target by 2030 by Government of India and WHO that maternal mortality should be less than 67, and same way infant mortality should be less than 12. And it is possible only with we go join hand on part of government, federation like FOXY, IMA, and all the obstetrician friends, particularly working in rural area. And if we concentrate on women's health, and particularly during antenatal period, to pick up high-risk pregnancy cases and promote institutional delivery, then it is possible. And there are so many states, particularly I can say in southern India, say for example Kerala, they have already achieved goal by 30 and even less than that. There are few states at the same time that in northern eastern area or in northern area, still they are having maternal mortality rate near 200. And it's a matter of worry for all of us, all our Foxian friends and obstetrician friends working in rural India. And if we go join hand, just I mentioned prior, we can achieve this goal. And with this mission, we have kept for discussion today's topic is stillbirth. Of course, we know stillbirth is a very a typical condition, not only for patient or for a relative of patient or family members, but for gynecologists, obstetrician also to deal with the situation and to deal with emotion of patient and relative also. So we have selected learned faculties for the same, and I am quite hopeful that we are going to be benefited with today's discussion to check maternal mortality and infant mortality in future. So thanking you all again. Welcome to this 231st episode of Happy Learning Masterclass. Thank you. Thank you very much.
Thank you so much, sir. It is with our proud privilege that Dr. Shobha Pattar, Madam, past president of the Kasoga, is with us today as the chief guest. She is the director of Pattar's Fertility and Research Center, the past chairperson of Karnataka chapter in SAP, the past president of Kasoga, Executive Member of the PCOS Society, and Vice President of the Fertility Preservation Society in India. Madam has the first in Karnataka to be accredited at the entry-level NABH with the National Accreditation for the Healthcare. She's also the first in... Can we mute the rest of the others, please? First in North Kannada to offer a fellowship course in reproductive medicine under the RUGA. She's also first in North Kannada to achieve a successful PGTA pregnancy. She is a recipient of many excellent awards, including the AHPI Award of the Quality Beyond Accreditation for 2 consecutive years. She's a visiting professor and PhD guide, a fellowship in perinatalology from the University of Illinois, Chicago, and fellow of the ICOG. We welcome you, ma'am, and we request you to please share your words of wisdom.
Thank you very much, Monica, for that kind introduction. Good evening, everyone. It's truly a privilege to join this Happy Learning webinar series as a chief guest for such an important session on stillbirth. And I must congratulate Dr. MC Patel, sir, for that number of 231 editions. Oh my God. It's such a truly incredible and inspiring journey he has had. And since the COVID times, he has been doing this. I've been a part of this program several times earlier as well. So coming to the today's topic, we know the stillbirth is one of the most traumatic experience a woman goes through, not only a woman, a couple, but family, but also the obstetrician. We have had severe experience in our own life, I think, where we had, stillbirth, and I'm sure we have left with so many unanswered questions. So globally, if you look at it, stillbirth remains a major challenge. Nearly about 1.3 million babies were stillborn in 2023. And if you look at it, there's a huge disparity between developing and developed countries, highlighting the fact that many of these stillbirths are potentially preventable with the timely and quality care. And also the stillbirth is often silent, underreported, under-discussed. So somehow, it goes, though it has such a profound impact, it is not discussed much. I'm so happy that you're bringing up this topic today. Having said that, internationally, there is a lot of work has been done on stillbirth by WHO, UNICEF, Newborn Action Plan, International Stillbirth Alliance, and also Lancet, landmark study series from Lancet Stillbirth series. Starting from 2011, they have brought a lot of system understanding to better care for the patients who have this loss. And I'm sure these are all going to be discussed in the next couple of hours. In India also, we have this India Newborn Action Plan, which aligns with the global goals and aiming to reduce the stillbirth rate to single digit by 2030. Of course, we'll have a lot of challenges coming from the definitions and the classification and everything. I'm sure we have to go through that whole effort. So today, the webinar is not just an academic exercise. It's a commitment to understand, to prevent where possible, and how to care better. So every stillbirth should not leave us only with a grief. Every stillbirth, we have to ask this question: what happened? What went wrong? What we can do? So subsequently, what are we going to do? So I think these are the questions which we have to ask every time we are faced with this case like this. And I congratulate the organizer for bringing up such an important topic, which I'm sure at the end of the webinar will be more knowledgeable, will have more insight, and will be more sensitive to deal with the patient who has gone through this loss of a stillborn baby. And I thank you very much. And I hope that this webinar will be a great success. Thank you so very much.
Thank you, Madam, for sparing time for us. Of course,
my pleasure, sir. My pleasure.
Mentioned prior also, you are always with us in any of our academic activity. Thank you, Madam.
Thank you, sir.
Thank you, Shobna ma'am. You rightly put in all the purpose of this webinar together, and the main aim that we are together here for discussing stillbirth, the etiopathogenesis, as well as the fetal surveillance. Thank you so much for joining us today. I would now request Dr. Monica Gupta madam to please introduce our guest of honor, Dr. Vidya Thobi madam.
Thank you, Monica, for giving me opportunity, and MC Patel, sir, for making me part of this program. Today,
the tech team, please change the slides, please.
Guests of honor are Dr. Ballard, sir, Dr. Vidya Thobi, ma'am, and Dr. Durga Das Ashrana, sir. Please put the CVs of Vidya Thobi, ma'am. First. Madam is a professor and former HOD from Vijayapur, and she was a chairperson for Food, Drug and Medico-Surgical Equipment Committee, for which she has received Best Committee Award in 2020. She is a ICOG Governing Council member. She has received Foxy Champion Award. She was a national national corresponding editor of Jogi, organizing chairperson of Kasoga 23. She was a president of Birjapur OBGY Society as well as secretary in 2007. Over to you, madam, for your words of wisdom. I think madam is not there. Madam is not there.
मैम ने
Whenever
ज्वाइन तो
madam,
किया था
huh?
दिख रहे हाँ अब
मैम
नहीं
अभी तो थे 2 मिनट पहले.
हाँ अभी पहले she was in the car maybe there is connectivity problem we met her right now no we met her
Yeah.
he said hello to
Ma'am,
us.
actually, Durgadas sir is in an emergency, so he will not be able to join. But I cannot get through Bellard sir because his number is not reachable right now.
Okay.
So you can just introduce both of them also. We will take their blessings when as and when they join.
Okay.
Yes,
ठीक है
ma'am.
Please put the CV of Ballard, sir. Sir is a highly academician. He was a president of Kasoga OBGY Society in 1819 and Secretary General of Kasoga in 1213. And he has received Teachers of Teachers Award. He is FRCOG Best Scientist Award, Best Teachers Award, MS Signature International Award, and he's been instrumental in many of the research, publication, and editorial roles. He's a principal investigator for major international trials in labor, CLIP, preterm labor, CRADLE, cradle, clindamycin, and so on. He has 85% plus publication. He has written 2 books and contributed chapters in 18 books. And he has delivered regional to international conferences, 1500 plus lecture. He's a highly academician and we will really miss him if we don't get him his blessings. We are trying to reach him. Next. Please put the CV of Durgadas Arsana sir. Next. He's the president of, next please. Next slide, please. Durgadas Arsana sir, he's a president of Karnataka OBGY Society and he's a past president of Tumkur OBGY Society and associate professor in Sri Siddharth Medical College, Tumkur. And he's a consultant in Kasturba Hospital, Tumkur. And he's a member of so many societies like IMS and ISOPAP. Whenever he joins, we will take his blessings. Over to Monica for further proceedings.
Thank you, Monica ma'am. MC Patel sir, can we start with the academic session in the meantime till people join?
Oh yes.
Because I think Vidya madam has not yet joined back, sir.
Whenever they join, we will have blessings at that time. No issue.
Sure, sir. Thank you, sir. I would now request Dr. Deepika Logane madam to please start with the first session.
Yeah. So good evening to everyone. And at the outset, I would like to thank Dr. MC Patel sir and Dr. Monica for giving me this opportunity. And we will be now starting with the scientific session. The session 1 is on etiology of stillbirth. And this is, as sir has already said, the 231st edition of the Happy Learning Masterclass on stillbirth, a matter of concern. I would like to introduce our first chairperson, invite Madam Dr. Rajeshwari Kapoor Patil, who is the secretary of the. Can we have the CV, please, for the session, for the first session?
The tech team, please change the slide. We need the third slide from now. Yeah. One more slide, please.
Just click further.
Previous
click
slides
further.
for the
This is
chairperson.
Yeah, go on further. We can come back to sir later. Yeah, keep clicking.
We need introduction for Dr. Rajeshwari madam.
Yeah,
please.
keep clicking
The next
further.
slide.
Yeah, just wait here. So our first chairperson is Dr. Rajeshwari Patil ma'am, who is the secretary of the Belgaum Obs and Gynecology. Madam is the director of Dr. Neelam ma'am, please can you mute yourself? Yeah, thank you, ma'am. So, madam is the director of Sunshine Hospital, Belgaum, with special interest in fetal medicine and reproductive medicine. Ma'am is also the executive member of the Menopausal Society of at Belgaum chapter and has numerous publications in national and international journals. Ma'am is widely respected for her clinical expertise and continued contribution to women's healthcare. Our second chairperson is Dr. Shailaja Bidri, ma'am, who is the president of the Vijaypur Obs and Gynae Society. Ma'am is the professor and head of department of BLDE Sri B.M. Patil Medical College at Vijaypura. Ma'am has been the executive committee member of Kasoga North Zone and honorary secretary of BOGS. She has contributed to major international trials like the Champions Trial, A+ trial, and Action trials. We welcome you, ma'am, as our chairperson. Can we go on to the next slide, please? Yeah. So our third chairperson for this session is Dr. Lata V. Ma'am is the president of the Chitradurg Obs and Gynae Society. She is the head of department and unit chief at Basaveshwara Medical College. And ma'am's interests include safe motherhood, infertility, and preventive oncology. And ma'am has actively led awareness programs on cervical cancer and HPV vaccination, and is the recipient of the Ambedkar Award for Academic Excellence. We welcome you, ma'am. And can I request our chairperson, Dr. Rajeshwari Patil, ma'am, to please kindly introduce our speaker for the first session, who is none other than Dr. Jeevan Reddy, sir, who will be speaking on etiology of stillbirth. So, tech team, you will have to move backwards because sir ka wo upar hai. Yeah. So, Dr. Patil, ma'am, can you introduce Dr. Reddy? Thank you, ma'am.
Thank you, ma'am. Thank you, Dr. Patel, sir, for giving me an opportunity to chair the session today. Today's our first speaker is Dr. Jeevan Reddy, sir. He's completed his MBBS from Bangalore Medical College and his MS from SCB Medical College, Cuttack. And he has expertise in FMAS and DMAS. And also he's a World Laparoscopy Hospital, Gurgaon. He's completed from there. Currently, he's serving as Associate Professor at Sridevi Institute of Medical Sciences. And he has his areas of special interest include high-risk pregnancy, minimal access surgery, adolescent health, cervical cancer prevention. He's an active member of prestigious professional bodies like FOXI, AGOI, PCOS Society of India, and he's a joint treasurer for TSOG. Dr. Jeevan Reddy, sir, has contributed to medical literature with multiple national and international publications and has recognized with many awards, including the prestigious Dr. Suli Rudra Sinha Prize. In addition to his clinical academic role, he is actively involved in training skills and development in serving certified instructors and course director in an emergency life passion for women's health.
So I request all other participants to please mute.
Ask you to continue with
Dr. Shweta,
today's topic.
Team, can you please mute the others?
Thank you.
Yeah, thank you. So we welcome you, Dr. Reddy. Sir, I think I sent the presentation to the tech team. Have you got the presentation?
Yeah.
Yeah. So, sir, with your permission, can we start sharing your presentation?
Yes, ma'am. Please go.
Thank you, sir. Thank you, sir.
Is it ready, ma'am? Can I start?
Just a moment. No, it's right now not on the screen.
Sure.
I've shared it. I think he's opening it.
Yeah.
Soumya, where are you? Acha, one patient is there waiting to get delivered.
Can we ask the others to mute themselves, please?
Okay. Please come and see her. Yeah, I will. Please.
Tech team, have you got sir's PPT? I shared it with you.
Yeah.
Okay, आप कर रहे हो? हाँ, ठीक है. Okay, all right. Thank you.
I believe it's visible to everyone.
Yeah, it's visible.
Yeah.
Please make it full screen.
Yeah.
So, very good evening to everybody, and I'm very grateful and I'm very thankful for giving me this opportunity to be a part of this great webinar. So, when I was given 3 days ago to talk about the etiology of stillbirth, I was kind of wondering what would I talk for 20 minutes, which is not already in the books, which we all are aware of anyway. So, I did a bit of research and I'll just share the things with you. So why do we need to talk about the stillbirths? So much has been told by Dr. MC Patel sir and all the other senior stalwarts here. I just wanted to highlight that it's such a devastating thing for the mother, for the family, and we are so behind. As in, India contributes the maximum to the stillbirths, and yet we don't know like what are the causes, where we go wrong, what can be done to improve. I mean, we do know, but we have a large scope for improvement. And let's just take a look at the etiology of stillbirth, and then we'll learn. Next slide, please. So the definition, the trouble starts from here. There are no uniform protocols to define what is stillbirth. There are no uniform protocols to distinguish between stillbirth and IUD. There are no uniform protocols to how to evaluate, how to get to the cause of the stillbirth. That's where we can safely say that whenever we report a stillbirth, almost 30 to 40% of the times, in most of the cases, up to 50% of the times, we do not find a cause for stillbirth. That's quite alarming. But when we look at the definitions, when we look at the cutoffs, then we realize that the first definition is by WHO. The first two are in fact from WHO. A baby who dies after 28 weeks of pregnancy, but before or during birth, is classified as stillbirth. The second one, baby born with no signs of life at 22 or more completed weeks of gestation. For international comparisons, 28 or more completed weeks of gestation are used. Now, we need to understand the weeks is different for different countries. Say for UK, they take it as 24 weeks. For US, they take it as 20 weeks. For India, 28 weeks. In certain setups, they take it as much lower. We just need to follow the protocols for each country. The third definition is from RCOG. The legal definition of stillbirth is any child expelled or issued forth from its mother after the 24th week of pregnancy that did not breathe or show any other signs of life. Next slide, please. Next slide, please. Yeah, here WHO again defines fetal death means death prior to the complete expulsion or extraction from the mother of a product of human conception, irrespective of the duration of pregnancy, and which is not in an induced termination of pregnancy. The death indicated by the fact after such expulsion or extraction that the fetus does not breathe or does not show any other evidence of life, such as beating of heart, pulsation of the umbilical cord, or definitive movement of the voluntary muscles. Next slide, please. This is the US National Center for Healthcare definition, which tells the delivery of any fetus showing no signs of life. Again, it's the same definition, but here they consider it as 20 weeks. Here, they've specifically mentioned that the terminations of pregnancy, which are done for life-limiting fetal anomalies or inductions for PPROM cases, they are not to be included as part of stillbirths, according to the US guidelines. Next slide, please. So here's the challenging part. What is stillbirth? What is IUFD? All through our teachings, we have been taught that when we find that there are no signs of life in utero, we consider it as an IUFD. Then stillbirth, as we have defined that, it was probably alive prior to the delivery, and during the process of labor, it has lost the life. But the differences are not so. I mean, they're not very different, and they're used very interchangeably these days. In saying that, I would like to highlight that most of the textbooks, most of the guidelines have done away with the term IUFD or IUD, and they are all coming to stillbirth. ACOG clearly mentions that stillbirth is the preferred term over fetal deaths, and all the guidelines, henceforth, they start talking about stillbirth. Now, here lies our confusion. We have traditionally been told that it was alive earlier, now it is dead after the or during the process of labor. But then they clearly mention that only up to 40% of the cases of stillbirth occur during labor. So most of them occur prior to the labor, then again, that means it is an IUFD. So there is not much of clarity between the two terms, and all the recent guidelines, all the recent textbooks stick to the word stillbirth, and we'll continue with the same. Next slide, please. So what's the burden? When I was told to talk about the etiology of stillbirth, I was thinking, how do I approach? And that is when I understood that if we look at the studies and the burden in the world, in India, and in the state of Karnataka, and the causes then and there, that is how we have a better clue at what is happening. Because, like I told, there are no uniform protocols. The age, gestational age, is entirely different. The reporting is extremely different. We, developing countries, underreported to an extent that we don't even know the exact incidence. So we'll just take a look at the burden and go further. Next slide, please. So according to WHO, this is the burden worldwide: 2 million births, stillbirths per year. That means 1 every 16 seconds. That's quite an astonishing number, and we are far from, delivering good health care to all the pregnant women all around the world. It directly reflects the kind of policies we have, the kind of healthcare services that each state, country, and private or government, anything that is able to provide or not. In this, it clearly states that only 40% of all the stillbirths occur during labor. So here are the gray areas in definitions. And like I said before, we will again stick with the stillbirth over fetal deaths. Stillbirths, according to the ENAP is that every newborn, an action to end preventable deaths. According to this, the 2030 goal is to have less than or equal to 12 stillbirths per 1,000 total births. As we all know, stillbirths are measured as the denominator is used as total births, that is live births plus stillbirths. And in that, the goal is to reach less than 12. Next slide, please. So here we can clearly see that India, accounting for up to 17% of the causes of, of the reasons of stillbirth, it is the maximum, it has the maximum burden of stillbirths. And we need to see that we fare much worse compared to a lot of other extremely poor, extremely challenged, and underdeveloped sub-Saharan countries. And India, being one of the global leaders, otherwise, we still are performing in a very bad way. Next slide, please. This, thankfully, we are not in one of these war-torn nations or one of these challenged nations. And this is just to represent that stillbirths directly indicate the existing political stability, economic stability, and existing, how well and how far are the countries able to provide healthcare, a sustainable healthcare to the mother. Next slide, please. So in this, the second graph tells us how much reduction should have been achieved so that the 2030 goal can be achieved. And we still are a long way far from what had to be achieved. They needed an achievement of the reduction of stillbirths by at least 5%, which we have not been able to reach yet, to reach our goal of less than 12 per 2030. Next slide, please. So where do most stillbirths happen? As we saw, India accounts for the most, that is 17% of it. And next is our neighbor Pakistan, Nigeria, Congo, Ethiopia, and Bangladesh. It's kind of sad that India is, in a league with these nations where they're almost failed nations, as we all know. Next one, please. So here are the major causes of stillbirth as WHO enlists: pregnancy and childbirth-related complications, prolonged pregnancy, maternal infections such as malaria, syphilis, and HIV, and conditions including hypertension, diabetes, obesity, fetal growth restriction. Congenital anomalies, on the other hand, account only for 10% of the stillbirths. We need to understand that the causes between the developing nations and the developed nations are extremely different. The sum of which is given by WHO here includes all that happen in both developing as well as developed nations. And we see that pregnancy and childbirth related complications are the most common. Of course, apart from undetermined cause, and then prolonged pregnancy, maternal infections, especially malaria, syphilis, and HIV in the developing nations. Conditions like obesity, hypertension, diabetes are more seen in developed countries. Fetal growth restriction, again, is a part of chronic placental insufficiency occurring because of these lifestyle changes, and congenital anomalies, as we can see, account only for 10% of the causes. Next slide, please. So here is a look at the Indian statistics and the Indian causes. So India accounts for about 17%, and as per multiple, again, see, in a country like India, we do not have a uniform system of accounting or reporting the stillbirths. So when we consider as per the CRS, that is civil registration system, it is 6.6 per 10,000 live births. Whereas when we consider HMIS, that is health management information system, it is around 12.4%. In that, we can also get to see that if we consider the cutoff of more than 28 weeks, it is lesser of 12.8 per 1,000 live births. I mean, sorry, total births. If we consider the gestational age of 24 to 28 weeks, including as well, we have a higher rate of stillbirth, that is 16.2 per total births, 1,000 total births. Then if we consider more than 20 weeks, we get a 22 rate of per 1,000 total births. Here, we need to understand the point that India is such a diverse country. We have poor people, yes. We have underdeveloped people, yes. But we are in that state where urban poor are more prone towards the lifestyle diseases. We have come to a condition where we are not entirely a developed nation. We are not entirely a developing nation. We have all kinds of risk factors combined with our lack of exercise, our lack of, just leading a decent lifestyle, how we approach healthcare. That all of that reflects in what we see further. Next slide, please. Next slide, please. Next slide, please. Yeah, here we can see that figure C shows 2021 update of what burden is there in India, and the red regions have reduced quite a bit, but we still can figure out that the Bimaru states, as they're sadly called, they all account for most of what India accounts for, in the global platform. Next slide, please. But we also need to notice, as per this diagram, that the division is not quite uniform within the states as well. When we see a lot of high burden districts are accounted for in multiple states, including the well-performing southern states, we can see the North Karnataka states, some districts, and some districts in Tamil Nadu, Andhra, and Telangana as well have performed in a much worse way when we compare it to the well-performing districts. Next slide, please. Here are the risk factors that were considered in the Indian studies for stillbirth, and these are very much relevant. High risk fertility behavior means the artificial reproduction techniques, the education of women, age at the first birth, if it is less than 19 years, if it is more than 35 years, due to its own set of all the risk factors that we know that come along with the teenage pregnancy. Once we cross 35, we have obesity, diabetes, eclampsia, chronic hypertension by then, and a lot of congenital anomalies. Then height in women, tobacco use. Was the baby wanted when the mother became pregnant? Does the mother drink alcohol? Media exposure. How well are the mothers, how aware are they to what is happening? Timings of ANC, the number of ANCs that they've had, the birth preparedness, the complications, readiness of the complications, getting medical help whenever needed. We saw that 40% of all the stillbirths are accounted during the process of labor. When we do not give them respectful maternity care, the bare minimum, something that, every woman deserves, they need to have that standard of care that has to be given, which we can't promise with the trainees and with the DIEs and with the newer generation of students who are becoming postgraduates and undergraduates who are very casual about what is happening. They fail to recognize how much of a devastating effect that stillbirths cause, and that is where the kind of care that we are providing plays one of the most vital roles as to how and why we are still the most stillbirths. We are the country which has the most number of stillbirths. Then we can see perceived quality of ANC, the quality, not just the number of ANCs, and experience in complications. How many of them experience complications during the pregnancy? How many of them develop preeclampsia, hypertension, diabetes, or any of that? Place of delivery. Where did the delivery occur? Place of delivery, was it in a public hospital, or is in a private, or uh, a home delivery? What was the anemia level? Who was the household head? Is it a male or a female? All of these factors individually made a difference, and all of them counted for the increase in the number of stillbirths. Qualities of ANC, source of drinking water, cooking, wealth status, family size. We can directly see and say that this entire thing, can others please mute? This entire thing is a reflection of how well we are performing as a society. And can we go to the next slide, please? So according to the Lancet study, 40% are reported, and they are mostly after 28 weeks. But if we consider after 20 weeks, we will start realizing that we are not accounting for almost 2/5 to 3/5 of stillbirths that are happening around in India. So we should understand that without adequate reporting, considering only after 28 weeks, with such a large number, we still perform so bad. Imagine if we were to starting to include more than 20 weeks, considering all the things and having a uniform reporting system. I think our rate would probably shoot through the roof. Can we go to the next slide, please? So these were the major risk factors that were found out from the studies that were done in India. Like I said, there are no uniform studies. So multiple studies were picked up, and a journal was published in Lancet accounting for these things: illiteracy, short maternal stature, anemia, unclean cooking fuel, rural residents, scheduled castes. All of these, they acted as a major risk factors. Lower risk was observed in women who were wanting to delay pregnancy. That means they conceived when they wanted, they took adequate care, they accessed whenever they needed any medical help. That kind of pregnancy had a much lesser chance of stillbirth. Next slide, please. So here is a report published from the government of Karnataka in 2025. The government of Karnataka is worried about the rise in stillbirth. Though, can we go to the next slide, please? We'll look at the rates. Here again, you can see the high burden districts. When you compare it to the earlier years of 2010, by 2022, the high burden districts have definitely reduced, but we still see somewhere in and around Dharwad, Haveri, the burden is quite high, and the social status reflects it altogether. Next slide, please. So overall, Karnataka has 3.41 per 10,000 total births. When we compare it to the national average, it's pretty good, but we have poorly performing districts like Chamarajanagar, Dharwad, Haveri, Gadag, and Mysuru. And we need to see the shift here that urban areas are getting affected more. We are sedentary. By our default, we are becoming sedentary. We do not have access to good food. We do not have access to good health. And though we live in urban areas, a lot of urban middle income countries cannot afford to have a decent lifestyle because of the constraints of time, money, and just about the information and everything. And all of that is individually pushing us towards having more and more stillbirths. Next slide, please. So in the Karnataka stillbirths that were discussed, we have major causes related to birth-related stress, that is during the labor events, breathing issues during delivery, slow fetal growth, strenuous work during pregnancy, lifestyle and health factors, like I said, are a predominant thing. Delayed hospital arrival and refusal of cesarean section, in many cases, they all accounted for all of the stillbirth causes as seen in 2024 as per the Karnataka census. Next slide, please. Next slide, please. We have discussed all the risk factors. Here is a tabulation of, next slide. Here is a tabulation of all the risk factors that we have. And we need to understand that all pregnancies have some risk, but with each condition, with each variable that extra adds up, we add up the risk. That is, diabetes, hypertension, growth restriction, multiple gestation, oligohydramnios, late-term pregnancies, teenage pregnancies, elderly pregnancies, previous history of stillbirth, decreased fetal movements, and the rarer or causes that are seen more in the developed nations, SLEs, APLAS, ARTs, obesity, smoking. A lot of our women have started smoking, be it first-hand smoking or be it second-hand smoking, passive smoking, when they're exposed to smoke on a regular basis because of multiple other people. That also is accounting for a lot of stillbirth. And drugs, we fail to address the problem that we think drugs are not that prevalent in the society, but we really fail to understand that drugs are very, very widely available, very easily available, and very much prevalent in today's generation. And we should be very cautious when we are going to address these people as our next mothers. And we need to keep an open, non-judgmental mind that this could probably be a cause, and start addressing as early as possible, preconceptionally, during the conception, whenever we can. We need to keep an open mind that substance drug abuse has risen a lot in India, at least in the recent times. Next slide, please. So the potential causes of stillbirth, of all the things that we have seen, apart from the labor events, we have fetal growth restriction, placental abruption, chromosomal genetic anomalies, infections, umbilical cord events that account for most of the stillbirths, at least as reported by traditional colleges and traditional textbooks. With this, I think I've covered most of the causes. I know I've not gone with the traditional textbook method of these are the causes, these are the risk factors. I just wanted to take a look at what is happening worldwide in India and in Karnataka, and the reasons that have been listed out from the studies that have given out the incidences in each of these. And I think we've reached the end of it. Thanks a lot again for giving me this opportunity, and I'm open to any questions there are.
Thank you, sir. It was a wonderful talk. It was crisp and covering completely giving overview of the etiology in a different way. It was rather a different way than what it was expected to, listing out the etiological factors. Thank you, sir. It was a wonderful talk. Can we have questions for sir, if anybody have they typed?
Ma'am, I don't see any questions in the chat box. However, if anybody wants to ask questions, they're more than welcome.
Yes, ma'am.
Sure. Thanks again for the wonderful job. Thank you very much.
I think Dr. Jeevan did a wonderful job of it, and there are really no questions. The audience is still recovering from what you've said. We are all speechless, and we're just like trying to amalgamate whatever you said, and it was wonderful in one line. Absolutely wonderful. And thank you, chairpersons, for chairing the session, as well as Dr. Jeevan for delivering that excellent talk on etiology of stillbirth. Really putting us as a nation something to be not that proud of at all. Yeah, Dr. Megha, would you like to say something?
Thanks.
Dr. Megha's network is like.
Thank you, ma'am.
Okay. Fine.
Nivedita ma'am,
yes.
Ma'am, Megha madam has just called up. She's washing up for a cesarean section. We will take Patel sir's talk first.
Okay, fine.
Yes, ma'am. So we can keep the chairpersons the same, only the speaker changes, ma'am.
Okay, we keep the chairperson the same. Okay, fine.
Yes, ma'am.
Or we can take session 3 first and then session 2, whichever way you want. Dr. Monica.
Whatever is comfortable, ma'am. Whoever is joined in accordingly, you can decide.
For the chairperson, would you like to, the chairpersons of session 2, Dr. Manohar and Dr. Ranganath, would you like to chair the session of Dr. MC Patel, sir? Then I'll invite you. Okay. I think we can go with them. So, okay, now moving on to session 3 with the chairpersons of session 2. Session 3, we have, as always, the most gifted medical legal expert of FOXI, Dr. MC Patel, sir, who's going to speak on the aftermath of stillbirth. And to chair the sessions, we have the president of Mandya Obs and Gynae Society and the president of Raichur Obs and Gynae Society. So Dr. Manohar R is an associate professor of the Institute of Mandya Institute of Medical Sciences. He is an undergraduate and postgraduate examiner since 2013 to MGR University, NTR University, as well as Kerala University. With number of prizes for poster presentations and critical care in obstetrics. His area of interest is high-risk obstetrics and infertility. The next chairperson for this series is Dr. Ranganath. He is the Chief Consultant and Medical Director of Asray Fertility Center, Linga Subur in Raichur. And he's worked as a consultant in Craft IVF Center, Kodungalur, if I get the pronunciation right, Kerala. And he started Asray Fertility Center in 2010. He's started the IVF and ICSI centers in 3 cities, and since 2019 presented multiple papers in national and UFOXIs, awarded the Healthcare Excellence Award by AsiaNet, Suvarna News Channel in 2023, and the Basavasri Kalpaka Award in 2023. Welcoming the respected chairpersons to this session of Dr. MC Patel, sir. Would any of the chairpersons like to introduce Dr. MC Patel, sir? Do we have the chairpersons in the session here? Or maybe, okay, fine. Dr. MC Patel, sir, I don't think he really needs an introduction to this August gathering. He's been the past vice president of FOXI. He has his highlights are the FOXI uniform consent, the medical legal training and support for members, chairperson ethics and medical legal committee 2011 to 13, organizing secretary AICOG 217, the organizing chairperson for MMCon, VPCon in 2018, honorary member FOXI, PNDT, violence against doctors and regulatory cells. On a community service level, he is an honorary surgeon, Red Cross IBank. He provides services in medical camps in Northeast states under the Dhanvantri Seva Yatra, under the NMO and Seva Bharati organized since 23 years. He's got services in medical camps in Jammu and Kashmir under the Dhanvantri Seva Yatra, under the NMO and Seva Bharati organized since 6 years. And he's the president of Lions Club, Ghatlodiya since 1977, 1990 to 1998. He's been the president of AOGS, president of IMA Ahmedabad, the national president NMO, as well as the organizing chairperson Vivekananda NMO Con in 2013. His major areas on which he stresses are ethics, training, compliance, community service, and vision of safe mother and safe child. Over to you, sir, for your talk on stillbirth and its aftermath.
Thank you, Nivedita, for kind words. Let me allow to share my screen. Is it seen full screen?
It's seen, but not in full screen, sir.
Is it now?
No, sir.
Still not?
No, sir.
In my computer, it is seen full screen. Now?
Yes, sir. It is full screen, sir, now.
Okay. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. Yes. Yes, is it seen?
Yes, sir.
And it is in full screen.
Yes, sir.
Yes. So thank you all the society who have joined this webinar, and President and Secretary of respective society, and all the delegates, all the guests, and all learned faculty. But before I go to the subject, it is my humble appeal to endorse my candidature for post of President Foxy election year 2026. And all the President and Secretary, you will receive communication from Foxy either in last week of April or in first week of May for nomination. This time it is e-nomination. You have to simply open the link and you will see few names, and out of those names you have to select for post of president. So you have to simply select my name and click on my name, and your society will be nominating my candidature. And at the time of election, during August 1 to 10, you all will have to vote for me and makes other also to vote for me. This is my humble appeal. IUFD, aftermath and beyond. Usually I start any of my talk with this question: is it worth discussing? Yes, and if it is yes, then why? Medical litigations are increasing in number constantly and steadily. And as we know, whether it is IUFD or whether it is stillbirth, whichever we define the way, but once it is the case, these are the potential cases as far as litigation is concerned, and we should be very careful to deal with this type of cases. And we gynecologists rank first as far as any medical legal consequences are concerned in any area you select. Either it is civil suit, it is criminal case, Human Rights Commission, government, or NMC. Wherever you go, gynecologists are in driving seat. And we are working in this era. As such, I have searched in Google about my illness and medicine, etc. But I thought, let me have a second opinion from you. So we have to work with this type of people nowadays, and we should be very careful. And just I mentioned, these are the potential areas as far as litigation is concerned. We take utmost care of any of our patients not to end up into any kind of mortality or morbidity, but we never know. Accident may happen. And once accident happens, then it becomes a question for us to deal with the situation accordingly. And our situation is like this: we have to save mother, we have to save baby, and at the same time we have to save our own cap, and this is our own obstetric practice. Let us see, these are the few cases which are really happened in India and decided in different courts. It was regular antenatal checkup, sonography every time, told everything to be normal except polyhydramnios. At 34 weeks, during routine antenatal checkup, it was found to be a case of intrauterine fetal death. Advised cesarean section, preoperative investigations were advised, and blood sugar came out to be 432, which were never advised in past. So case was filed, notice was served, compensation demanded 1 crore. Still case is on, and let us see how doctor faced this situation. But it is very difficult in this type of situation to face the situation. Let us see one more case. It was again unbooked patient, primary 34 weeks of pregnancy with PIH, advised necessary investigation and treatment. Very next day she developed abruptio and intrauterine fetal death. Cesarean section was advised. Relative opted option to go for second opinion in nearby town. They went to surgeon. Cesarean section was done. But again, unlucky patient, and that surgeon too, she developed atonic PPH and hysterectomy was done. Notice was served. Imagine the situation: primary patient, intrauterine fetal death, and hysterectomy. So allegation to first gynecologist was not properly managed to prevent abruptio and IUFD, and to surgeon not tried to prevent PPH, and atonic PPH was not managed properly. I was defending both of them. So in court of law, as far as first gynecologist was concerned, it was very first visit with that very gynecologist of this patient, because this patient was taken care by another gynecologist in another town at his in-laws place. And in Gujarat, it is traditional, customary tradition that first delivery should be at maternal place. So she had been to this gynecologist with his mother, and it was very first visit. Our gynecologist had advised all the necessary investigation with treatment of PIH. But patient was unlucky that very next day she developed abruptio and IUFD. So we could convince court that as far as role of gynecologist on first visit of any patient is concerned, we had advised everything which any prudent gynecologist would have advised. So gynecologist was out of problem. As far as surgeon part is concerned, he had taken utmost care as far as PPH part is concerned. Particularly it was case of atonic PPH. So he went with oxytocin, ergometrin, stepwise devascularization, compressive suture, 2 units of PCV. And in spite of all these efforts, bleeding was not getting control. So to save life of patient, there was only way to go for hysterectomy, and hysterectomy was done. So during discussion, I could convince court what is atonic PPH and how it occurs, what would be the treatment protocol or treatment part of treating a doctor. So the court was convinced, and in this case, the surgeon was also out of problem. So both surgeon and gynecologist were not held responsible for all these consequences. But this type of emergencies may happen in our day-to-day practice, and many times it happens. Doctor, you said everything was all right just 10 days back. And now, how it happened? How you are telling that it is a case of IUFD? So we have to face this type of situation many times in our day-to-day practice. And it has great physical, emotional, psychological, and social trauma for parents and family. And it is very difficult for gynecologists to face this situation also. So care beyond, when once it is IUFD, now how to manage that very patient is the utmost concern for us, not to end up into any kind of further problem. So first goal is confirm diagnosis. 50% of stillbirths are preceded by decreased fetal movement, sometimes fetal movement perceived even after IUFD. So fetal movements can correlation as false positive rates at least up to 30%. Auscultation may be inaccurate. With inaudible fetal heart sound, baby may be viable. So gold standard is ultrasound, because with ultrasound we will locate placenta, its location, and retroplacental blood also. And as far as fetal part is concerned, presentation, approximate weight, Spalding sign. If it is old IUFD, then we will see Spalding sign also, high drops, and gross anomaly. If at all baby is having gross anomaly, then with ultrasonography findings, we will come to the conclusion. So it is gold standard as far as to confirm diagnosis of IUFD is concerned. So exclude immediate severe maternal morbidity is our goal. Once diagnosis is confirmed, then how to manage this patient further. So what is the path ahead? Exclude immediate severe maternal morbidity, and exclude immediate severe morbidity like this. If patient is having acute abdominal pain, then we have to rule out abruption. If patient is having bleeding, then we have to see for that also. Labor symptoms, PPROM, obstetric emergency like eclampsia and maternal collapse. And if failed to detect, to manage in time, then it is considered carelessness and negligence on part of treating doctor. So we have to diagnose the situation well in time, and we have to manage that very situation way in which any prudent gynecologist would have managed. Evaluate probable causes of IUFD. So very nicely covered by Dr. Jeevan as far as etiology of stillbirth is concerned. So I do not want to go into detail, but very quickly we have to go for evaluation of probable cause of IUFD, because it is a concern for management also. How we have to manage that patient further, we will have some clue with that information. As far as communication is concerned, to the patient or next to of kin and with relevant authority is very difficult task. As far as relevant authority is concerned, wherever you are working in some institution, there is a protocol to inform head of the unit, head of the department, and superintendent also. So we have to do that also. But as far as communication with patient and patient party is concerned, it is a very difficult task, but we have to manage that also. So as far as breaking bad news is concerned, most terrible thing that can happen to an obstetrician to declare bad news. Where do we go from here? It is very important part. If you are having RUSH team in your society, you can avail services from member of RUSH team, because to declare bad news alone or in presence of few of our friends, it is a very different story. And if we are having RUSH team in our society, then always involve our professional colleague at the time of declaring bad news. But at the time of declaring bad news, it is very clear that main chair belongs to owner or head of the team who has managed the case. Many times, person who have come for help could be senior, but even then, main chair will be belonging to person who is head of the team as far as management part is concerned. And communication is his job only, and role of RUSH team is only facilitating the situation. Do not take it as an opportunity to settle score by giving subtle hints to relatives that there was negligence on part of treating doctor. Many times we observe this may happen that a member of RUSH team are there, and when they are main of the head of the team is explaining to the relative, many times senior person in the audience, this presence, they will tell somebody in the audience, can you recollect that very case you had been to me with that very patient with severe condition, and with all our efforts we could save patient and baby both. This type of loose comment may be very troublesome for a person who is facing this situation of IUFD in his clinic. Communication with relative, just I mentioned, it is a very difficult task, but it is a task to be handled very intelligently. हम आपके बच्चे को बचा नहीं सके. It seems very simple in Hindi film, but in our day-to-day practice, it is not that simple to say like this. Inform condition from time to time. If we are dealing with a high-risk pregnancy cases, we know sudden IUFD is known in few of the cases, say for example GDM, say for example severe preeclampsia, eclampsia. So in this type of situation, always inform relative from time to time as far as condition of patient is concerned. GDM, severe preeclampsia, eclampsia, severe IUGR, abruptio. So we have to explain all this to the patient. And if we are sure of diagnosis, then on the admission only we have to explain everything to the relative that anything may happen in this type of situation. And if we have explained in the beginning, then it becomes very easy to face the situation if at all it ended into IUFD or so. By senior most person, just I mentioned, not by junior person. Be polite, sympathetic, but assertive at the time of declaring bad news. Be prepared for knee-jerk hostile reaction, because it is all likely that we never know what could be the reaction on part of relative at the time of this type of bad news. Be prepared for mob frenzy. Also, do not lose patience. Many a time there are so many questions bombarded on part of relative, and when one more relative enters the crowd, they will start asking the same question again and again. So in this type of situation, we have to keep patience, and we have to answer all those questions asked by the patient and relative of the patient in this type of situation. Do not blame each other. When more than one person is involved in managing that very case, do not blame each other, because it becomes worse condition many times when you blame each other to face before honorable court if at all you are facing litigation, and at that point of time before patient and relative. Use private room at the time of declaring bad news, not in ward or not in other area. Arrange interpreter if necessary. If you are not well versed with the language which patient understand, you can invite interpreter also, but always prefer interpreter who is not relative of the patient, because many times what he or she interprets, we never know. So we should be careful at the time of selecting interpreter also. discuss care and decision with both parents and or a support person, and document plan of care. So now onward, how you are going to manage that very patient should also be discussed with patient and relative. Nurse, registrar, other members of your multidisciplinary team should be available to give parents further information about diagnosis and outcome. But before they are available to relative for any query, any question, you will have word with all your staff separately before declaring bad news and before inviting patient or relative to declare all this news. Actually, what was the problem, what happened, what we have done, and what should be the answer on part of our team to the relative of the patient should be explained to the staff in our hospital. Because many times what happens, one staff will say something different and other staff will say something different, and it becomes difficult for us to explain to the relative whenever this type of conversation goes. So it is always better to have a word with our staff and then only declare to relative. As far as management plan is concerned, delivery and certain investigation, if we are going to go for expectant part of treatment, if there is some other indication, then we have to switch over to cesarean section or to quick delivery in this type of situation. Care of stillborn baby, it is very important part in this type of situation. So get verbal consent for initial examination from patient and relative. Offer parents opportunity to dress and hold the baby, because many a time relative are interested to dress the baby and hold the baby and to have a photographs also. Assist parent taking in photographs in this type of situation. So this is a list of mementos we have to take or we have to offer to the patient and patient party. Hand and footprints, lock of hair, name band, cord clamp, memory box, photographs, whole body, X-ray infantogram, and ultrasound scan we have to offer to the patient and relative. So as far as fetal autopsy is concerned, we have to advise them, but it is a very personal decision on part of patient and relative. If they are agree, then it's fine. We can manage for fetal autopsy. But if they are not ready, then we have to explain them. But at the same time, we have to keep this in mind. It helps in diagnosis in cause of death or add information in 22 to 76% of the cases when we offer autopsy. May change final diagnosis or affect genetic counseling also if we go for autopsy. In clinically unexplained stillbirth or relevant condition at death, classification is recommended. So we can explain about importance of autopsy, but final decision will be on part of patient and relative. If they decline with autopsy, if they are not ready to go for autopsy, then we have to go for full body examination, of course, outside by neonatologist or pediatrician or pathologist. But for the same also, we have to take consent from patient and relative for external examination, and it is very much must if we are going to go for some clinical photographs of that very baby. Do not forget, the bereaved parents need a lots of support. Each person is different and will go through their own grief as it suits their own personality, and you cannot do anything to make it better, but you can be there with them to offer them all other management and treatment plan further. As far as documentation is concerned, naturally these are the cases, potential cases for litigation. So we should be very careful as far as documentation and record keeping is concerned. What was the case? How we have managed this case till that point of time, and all the records, all the documentation, all the investigation we have done during antenatal period, during perinatal period, we have to mention everything in the in record. So our documentation should be up to date. As far as record keeping is concerned, OPD case paper, indoor case paper, whether patient was our book patient or if it is an emergency patient, then we have to mention everything as far as detail of the patient is concerned in a particular case. So this is a checklist as far as documentation is concerned. As far as maternal side is concerned, physical examination, comorbidity, if patient is having any comorbidity like GDM or severe preeclampsia or any liver disease or renal disease, whichever, we have to mention everything in detail. Emotional status of patient, and as far as scan findings are concerned, so presentation of baby, placental position, if any gross anomaly on part of baby as well as on part of placenta, then we have to mention that also. Amount of liquor, placental site, whether this IUFD was fresh or it was old, we have to mention that also. As far as baby part is concerned, gender, if it is possible, because many a time if we deliver macerated child, it is difficult to mention about gender, and we are not sure about gender, never mention probability. You have to simply say it is difficult to mention gender. Birth weight, gestational age, date and time of birth. If you are dealing with a twin pregnancy, then you have to label separately twin 1 and twin 2 as far as baby part is concerned. And if separate placenta, separate cord, we have to mention everything. And photo documentation is also a good part of documentation. If they allow, then you can go with those also. As far as local protocol is concerned, labor ward register, stillbirth certificate, notification, and we have to give all the information to our authority as per protocol in our institution where we work, and ensure discharge summary provided. It should be very accurate. What was the probable diagnosis for IUFD or stillbirth, and all the investigation we have advised, and now further plan of treatment. At the time of discharge, we have to mention everything about diet to be taken, medicine to be taken, follow-up visits, exercise. So we have to mention everything as far as breast part is concerned, because we have to manage that also, and we have to explain everything in detail to the patient, how to take care of breast in this type of situation. Preventing further recurrence, because once it has happened, and if you have nicely managed the case, it is all likely that patient may turn up to you again for further management in future. So preventing reoccurrence is very much important part in this type of situation, because 592,000 stillbirths per year in India. Of course, this is little old figure, now it is little change, but 50% are intrapartum and 43% are growth restricted fetuses as far as fetal part is concerned. And in this situation, cannot we prevent all this? Of course, it is preventable, and we have to think for that also. So in future pregnancy, strengthen antenatal clinical screening. It is very much must. Sorry. Risk stratification, we have to explain everything to the patient and relative when we are going to plan for second pregnancy. Proper antenatal checkup, because to pick up antenatal risk factor is a key to management, not to end up into same problem in successive pregnancy. Clear referral algorithm. Whenever you are dealing with a high risk pregnancy, you can have opinion from your senior colleague also, not to end up into same problem again. Protocol based management, it is very much must. If you have managed patient as per standard protocol, either from FOXI, either from ICOG or from RCOG, it becomes a consent, because many a time when you are facing litigation, it shows your consent that you have taken utmost care of that very patient as per standard protocols and guideline. Skill training and equipments for management is very much must. Moral support to the couple is very important part, because once they have faced the situation in past, they are much more tense or worried or anxious not to end up into same problem again in future. So we have to support them morally also. As far as this part is concerned, certain points are avoidable factors in perinatal death, and we should be very much aware and concentrating on those points. Patient delayed in admission. It is all likely that patient starts labor pain at home and they delay as far as coming to the hospital, because few of the patient in so many states, they have wrong belief. If we go early, then cesarean section will be done. And many a time they have one wrong belief that in daytime, if we go hospital, then it is also likely to end into cesarean. So they delayed in admission many a time with this type of wrong belief. So we have to explain them during antenatal period, prompt admission as far as proper care is concerned. Delayed in care on admission to birth facility. Many a time patient is at hospital, but starting of the treatment may be delayed and it may lead to some problem in this type of situation. Delayed operative delivery. When there is a fetal distress or so, immediate cesarean section is ready and patients or relative who are present are not ready to give consent in this type of situation. They will say that our father-in-law or our husband are coming, and once they come, then only we will give consent. So in this type of situation also, we have to explain everything to the patient, what is the situation and why we cannot wait for other relative to come for consent. So we should be very clear in this situation. And at that point of time, if you have advised intervention either by operative delivery or by instrumental delivery, then and if they are not ready to give consent, you have to mention in the case paper and you have to get it signed by patient if patient is in a position to give sign, or by relative, and we have to mention everything to the relative. If at all you are going to give consent after 1 hour or so, then we cannot give guarantee. Which kind of guarantee we can give at this point of time should also be explained to the patient. Unavailability of health workers. Many times when patient start labor pain, and usually in remote area, they approach primary health center, and many times if health workers or doctor are not available, then they will have to be shifted to another center and precious time is wasted. Inadequate intrapartum monitoring. So this is also one of the causes to lead to IUFD and stillbirth in this type of situation. Misuse of oxytocin is one more area. Neonatal resuscitation facility should be there, and if it is not, in particularly in high risk pregnancy cases, then failure of neonatal resuscitation part is also one cause as far as fresh IUFD is concerned. So every newborn action plan targets neonatal stillbirth rate by 12 by 2030, and this goal is given by Government of India and WHO. So we all have to work together for this particular goal to achieve it by 2030. So you were born silent, perfect and beautiful, still loved, still missed, still remembered every day, still born, but still born. So question to face when we are dealing with this type of situation, stillbirth, we have delivered patient nicely, patient is fine, patient goes home, but we have to face so many questions in this type of situation. Was it preventable? Whatever has happened, was it preventable? And usually we cannot say no. And if it is yes, then one more question we will have to face. What did you do to prevent it? In spite of all these efforts, we couldn't prevent. And one more question will be asked, why you couldn't prevent it? And if at all any complication related to IUFD happens, then one more question, did you diagnose that complication well in time? And did you manage way in which any prudent gynecologist would have managed? So if you can answer all those questions, then you could be out of problem if at all you are facing litigation also, because every IUFD case is potential threat as far as litigations are concerned. So what to do and how to prevent? We have to practice foreseeability or anticipation, good communication and proper consent and proper documentation, and you could be out of problem. Law and court expect from us to anticipate certain complication, and we should be readily available to deal with those complications. Say, for example, if we are dealing with a case of GDM, severe preeclampsia, severe IUGR, severe anemia, then naturally we should be readily available to deal with all those situations, because these are the potential situations which may end up into IUFD, and we will have to face so many questions on part of patient and relative. So we should be very careful in this type of situation. And in this situation, proper counseling is very much must. We have to counsel patient very properly, which are the conditions, which could be the probable prognosis, which could be the probable outcome and probable complication, how we can deal with, what we expect on part of patient and relative as far as cooperation on part of them is required. No rosy picture about region. When we are dealing with this type of high-risk pregnancy cases, as far as IUFD or any major complication part is concerned, no rosy picture, no tall claim. Because in eye of law, when you claim to be master, you are supposed to be master. And in our obstetric practice, we consider result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture about result. You can give guarantee of your efforts, but cannot give guarantee as far as result is concerned. And records are always at your rescue. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. There is always a way. So to conclude with Kerry Holmes, always confirm IUFD by USG. Breaking the news of IUFD should be done very carefully and compensately. If it can help us avoid a lot of medical legal issues that can develop with this type of cases. Investigations are done primarily to find out cause of death. In spite of all test causes not found in 25 to 60% of the cases. So we have to explain that also to the patient. History taking is most important part in evaluating a case of IUFD. Vaginal delivery is preferred route unless it is contraindicated. Use prostaglandin with caution in scarred uterus with IUFD. Cytogenetic evaluation will be helpful where no apparent cause is found. A postmortem may be advised in certain cases, and fetal autopsy can provide an insight to the cause. An examination of placenta and HP of placenta in few of the cases also could be helpful in this type of situation. Be very vigilant in next pregnancy. Continuous support and reassurance is very much required in next pregnancy also. And in case, never take pregnancy beyond 39 weeks of pregnancy in women with history of IUFD. So pregnancy and labor room protocol and profile, we have to strictly follow protocols and checklist, proper counseling and proper consent, proper documentation, multi-speciality approach. Never hesitate to involve our professional colleague in certain condition, because it is always beneficial, not to the patient only, but to us also whenever we are facing any litigation or any odd situation. No compromise on statutory requirement. Whichever required statutorily, we have to observe all this. No compromise. Professional indemnity is very much must in era of CPA. So we should have adequate cover as far as indemnity is concerned. So be vigilant in your obstetric practice. Otherwise, be ready to face this type of situation in any day. So comply with the provisions of law. Whenever you are dealing with all these cases, we should be very careful about declaring bad news as far as documentation is concerned, but we have to comply with the provisions of law. Formation of local level medical legal cell or RUSS team, just I mentioned, at the time of declaring bad news, or at the time of surgical assistance, or at the time of in case of assault or mob violence or facing litigation. So member of RUSS team would be helpful in those very given situation. Take medical legal advice from point one if you are dealing with this type of cases. If at all you have apprehension that it could be ended into a medical legal problem, because this gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So God bless you. Have a litigation-free medical practice, because in spite of all these professional and occupational hazards, our journey to serve human and mankind is always on and on. So if you want to sleep like this, take tender care of your patient, strictly follow protocols as far as management is concerned, pray Almighty God before going to sleep, and keep my visiting card below your pillow. So with regard, salute to all. And before I conclude, still my commitment is there. Wherever you are, I will be there. Promise to reach unreached in any odd given situation. Seeking your blessings for post of President Foxy election year 2026. Please vote and canvass for my candidature. Thank you. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you. Thank you very much.
Thank you, sir. And requesting everyone to please come forward to and vote for him in large numbers. I would request the chairpersons, Dr. Manohar R. and Dr. Ranganath S. to speak a few words about this session before we move on to the next session.
Yes, I am Dr. Ranganath, Madam, Raichur Obstetrics Society President.
Yeah.
Actually, it is a very good initiative, and the topic chosen is also excellent, Madam, because this is really untouched area. Many problems we come across in the daily practices, but we don't know. We really face real problems during intrauterine fetal deaths only. That may be because of management part or antenatal part. And the real problem is convincing the patients and bystanders becomes real challenge, Madam, in this particular situation. Because for whom we have counseled, that those people will not be there in the scene when some untoward action has happened. That will become very tough job for us to convince the newcomers to explain and understand the situations. And this is really a very good session, and very nicely presented, sir. Dr. Patel is excellent, and he is also a legal expert, I feel. So
yes, sir.
Nice, Madam.
He's a medical
Nice.
legal expert.
Yes.
Thank you, Dr. Ranganath, sir. Anybody
Thank
else
you.
would like to say a few more words about this session? And any questions for Dr. Patel, sir? Then we move on to the next session. Okay.
Yes,
I think
let's move on to the next session, ma'am.
Right, Dr. Monica.
Yeah. It's a privilege to introduce our chairpersons, Dr. Abhijit Deshpande, sir, Dr. Raju Giradi, and Dr. Sumaya Firdaus, madam, for this session, which will be taken by Dr. Megha Kamlakurkar, madam, and she'll be speaking about fetal surveillance. Can we have the introductory slides, please? The next slide, please. The chairperson slide. Beta third chair session ka chairpersons. Tech team.
Next.
The next slide, please.
For session 3,
Session number 3,
Dr. MC
please
Patel
start
has been
session number
already-
3, chairpersons, please.
Yes, for session 3.
Actually, it was session 3 for me, but
Yes.
Dr.
But it
Megha
was
was
session
busy
2
with
for
one
the chairperson.
emergency.
Can you have
So we
Dr.
postponed
Abhijit,
it.
sir, slide, please?
So this is for session 3, where Dr. MC Patel sir has already taken, and this is session 2.
Beta, the
Fetal
chairpersons
surveillance.
are the same. Can you please show me Dr. Abhijit, sir, slide? You don't think about sessions. Please show me Dr. Abhijit, sir, slide.
Okay.
Yeah, thank you. So Dr. Abhijit sir is a senior consultant at Akshay Hospital at Belgaum. He is practicing since the last 28 years, and he has been associated with teaching at the KLEA Hospital as an adjunct post and graduate teacher. His areas of interest include critical care, surgical obstetrics, MTP, and ultrasound. We welcome you, sir. Our next chairperson, Dr. Raju Giradi, sir, holds a fellowship in fetal medicine under Dr. Adi Narayan, sir. He is a junior consultant and sonologist. He is also the chairperson of the Imaging Committee, Kasoga, and the secretary of the Raichur OBGYN Society from 25 to 26. We welcome you, sir. Our next chairperson, Dr. Sumaya Madam. The next slide, please. Yeah. Dr. Sumaya Madam is a consultant for the last 28 years and the medical director of City Hospital, Belgavi. She is the past president of the Belgavi OBGY Society and the joint secretary of the Indian Menopause Society at Belgavi chapter. She has been a faculty at various conferences. We welcome these chairpersons to please introduce our speaker, Dr. Megha Kamlapurkar Madam. Now, please show the CV of Dr. Megha Madam. Tech team. Thank you. I request Dr. Sumaya ma'am or Dr. Raju, if they are present, to please introduce Dr. Megha Kamlapurkar.
Namaste, very good evening, ma'am. Myself, Dr. Raju. Ma'am, it's truly an honor for me to introduce our speaker, Dr. Megha Kamlapurkar, who has been a remarkable teacher and a mentor to many, including myself. For people like me, she is a passionate about fetal medicine. She has been an inspiring guide. She's respected for her depth of knowledge, clarity in teaching, and her ability to simplify the concepts in fetal medicine. Her sessions are always insightful and clinically relevant. Madam is a director at Devata Hospital. She is president of ISOPAP Kalburgi chapter. She's executive member Medical Ultrasound Society Karnataka and member of FOXI and Fetal Medicine Committee. And she has a very special interest in fetal medicine, fetal heart and preventive obstetrics. And she's a very good classical singer in Hindu classical music. She's a very passionate teacher. I welcome you, ma'am. Thank you for giving this opportunity.
Thank you so much. A very good evening to everyone. See, my camera is not working, Monica. I'll just share my slides. Is it seen? Monica? Raju?
Yeah, ma'am, it's visible. You just need to put your
Go full screen, ma'am.
Yeah.
Yeah, it's visible.
Is it okay?
No.
Yes, ma'am.
Yes, ma'am.
Yeah, fine. Yeah.
A very good evening to everyone. Respected MC Patel sir, the program director for this program, convener Dr. Monica, today's coordinators, chief guests of honors, and chairpersons. It's very fortunate that Raju is the chairperson today for my talk, and really Raju has been a very passionate teacher, and there was a little correction in his CV that it has been mentioned as a junior consultant, but he is one of the very experienced, especially in gynae ultrasound, and he is being invited as a faculty for national and international workshops and on-site conferences. So with your permission of chairpersons, I will just start my session. So
Yes, ma'am,
for a
please start.
pregnant lady, she spends 9 months of her as painting her masterpiece in her mind. The color of his eyes, the sound of his laugh, the shape of his future, and suddenly, when everything ceases, she no more can talk to the baby, no more any perception. The canvas gets wiped off, blank, leaving her standing in an empty gallery of unfinished portrait. Fetal death is devastating for all the pregnant lady, for the family, and as well for the obstetrician. Stillbirths, still a neglected tragedy, as this shows. An estimated 2.6 million stillbirths still occur every year, and every day 7,000 women experience stillbirth. 60% of them they occur in rural areas, 90% occur in low and middle income countries, half of them occur in setting of conflict or emergency, and half occur during the labor. This is a very informative, picture which I could get from the net, which has been displayed by WHO, and we can as well display it in our consultation room or in our waiting area where the people can read and get aware of it. Making every baby count is an audit and review of stillbirths and neonatal deaths by WHO. And as I had discussed, that a stillborn baby is seen every 16 seconds. 84% occur in low, and again, to reiterate, lower middle income countries. 3 in 4 occur in sub-Saharan countries and Southern Asia. In every country, the risk of stillbirth is highest in the most vulnerable populations. And more than 40% of the stillbirths occur during labor and birth and are preventable with high quality care during pregnancy and birth. I could see only one slide by MC Patel sir, because I was held up in an emergency, that the litigation can occur if the consultant is not present during labor. And that was the reason I had to rush to the operation theater. So WHO, UNICEF and other partners, they have called for a renewed commitment to end preventable stillbirths by 2030. The Every Newborn Action Plan they have introduced, which includes a global target for stillbirth reduction, that all countries achieve a stillbirth rate of 12 or fewer or a single digit per 1,000 total births by 2030. So ending preventable newborn deaths and stillbirth is our mission now, and India is not behind. India has launched its more ambitious newborn action plan, that is called India Newborn Action Plan, INAP, in September 2014, setting a target of reducing NMR and stillbirth rates to a single digit by 2030 by improving access to quality antenatal and intranatal care to the mother. To achieve this, we need to target the preventable stillbirths. And my talk has taken the major references from this wonderful paper and guidelines by Manju Puri and all, Antenatal Care Bundle for Preventing Stillbirths, proposed intervention by Stillbirth Society of India. So we have Stillbirth Society of India, and that has given some guidelines to follow to prevent the stillbirths. International Classification of Diseases, which is now number 11, which is adopted by 72nd World Health Assembly in 2019, which has come into effect since 2022. It has defined stillbirth as the complete expulsion or extraction of a fetus from a woman following its death prior to the expulsion at 20 or more completed weeks of gestation. If gestational age is not known, the birth weight of 500 grams or more is used as identifying criteria. Stillbirths are strictly distinguished from cases of induced abortion, and 60 to 80% of the fetal deaths occur in antepartum period. How these are classified? The stillbirths are classified as antepartum and intrapartum because we need to audit them. And the earliest gestation stillbirths, which occur before 28 weeks or when the birth weight is 500 to up to 1 kg. And late gestational stillbirths, which occur from 28 weeks onwards or birth weight more than 1 kg. This is very important for auditing and to know what is actually the stillbirth rate in particular country. We have first speaker, he has given very elaborate details about the pathophysiology and risk factors for the stillbirth. We can divide them as maternal fetal factors, placental factors are called, etc. The major goal of antenatal care as such is the healthy mother and healthy baby, and it is the duty of every obstetrician to price the pregnancy as low risk or high risk. In the same way, we need to identify the fetuses which are at high risk of hypoxia, leading to oxygen deprivation or acidemia, which ultimately leads to fetal death, to allow for timely intervention and ensure fetal growth and well-being is our challenge. So what can be done? So we can have the risk assessment and intervention at booking, visit, or preconception visit. Here I want to stress that maternal surveillance and fetal surveillance will not be able to separate. We have to have it as a comprehensive unit. So maternal and fetal monitoring in second and third trimester will be discussing, and management of decreased fetal movements and management of low risk mothers diagnosed with fetal growth restriction. So preconception preventions for reduction of stillbirths can be detailed medical obstetric history to determine the risk factors of stillbirths, careful review of previous records for the cause of previous stillbirth, if any, referral for genetic counseling center if genetic cause is suspected in previous losses, advice on cessation of smoking, optimization, body mass, optimization of BMI, and correction of anemia. So these are grade 2, grade B, or level 2 evidences. The reference is by the same paper which has been published by Stillbirth Society of India. We need to ensure optimization of medical maternal disorders such as chronic hypertension, diabetes, epilepsy, thyroid disorders, including appropriate referral to specialists using multidisciplinary team approach and for switching over to for safer medications. We need to start aspirin prophylaxis preconceptionally if the woman is APLA positive or the history is suggesting. So risk stratification, actually we start as a journey, and healthy baby and with safe delivery is our destination. And there are various risk factors and how much risk is involved. The estimated risk of stillbirth can be this chart we can use for our counseling, saying that suppose the patient has history of preeclampsia without severe features, we can tell that there is a risk of 9 to 51 per 1,000 births of having you as a stillbirth. So when we discuss these things with the patient, definitely the patient, the family, and everybody and the consultant all will be cautious, vigilant for her journey and advise the proper maternal and fetal surveillance. When we see the pregnancy to delivery journey, we need to know that the first trimester screening we have to do, we have to take the history in details, see for the BMI, nutritional extremes, either anemia or obesity, see for the other investigations, routine antenatal investigations like screening for GDM and thyroid, and at around 11 to 14 weeks or 11 to 13 weeks, 6 days, we can offer her NT scan, where we can offer her aneuploidy screening, preeclampsia screening, and we can use Just2Swiss score and triage the patient as low risk or high risk. Here we can have this preeclampsia screening by triple test, which has been recommended by Fetal Medicine Foundation, which includes medical history, maternal characteristics, pregnancy characteristics, mean arterial pressure, mean uterine artery, PI, and PLGF concentration together to assess her risk for preeclampsia. So this is very useful site, Fetal Medicine Foundation, where it can give us the risk assessment. Everybody has phone in our hands or our assistants. We can immediately open the page, then feed whatever the columns are there, and then we can get the ultimate risk. The various risks are there available, but we can, in this case, we can have the stillbirth risk. So if we want to calculate the stillbirth risk, we can just open this page, enter this maternal age, weight, height, racial origin, chronic hypertension, smoking during pregnancy, and these previous obstetric history measurements at 11 to 13 weeks, which we normally do. Then previous obstetric history, everything we have to feed, and then this software will give us the risk for the stillbirth, and we can then disclose that with the family and the patient and can have the further surveillance. What in second trimester? In second trimester fetal surveillance, the frequency of visits, at least 8 antenatal visits in the first visit. With the first visit, preferably in the first trimester, around the NT scan. Then subsequent visits every month between 18 to 22 weeks, 24 to 26, 28 to 30, 30 to 34, and then every 2 weeks. This has been recommended by the Stillbirth Society of India. Then assessment of nutrition and weight triaging for her high risk as GDM, HDP infections, or intrahepatic cholestasis of pregnancy, and also we have to include the anti-D at 28 weeks. Apart from this, very important is the awareness of fetal movements. We need to sensitize the woman about the importance of fetal movements and immediate report to health facility if they perceive any decrease in fetal movements or change in the pattern after 28 weeks of pregnancy. So care for women who report to the hospital as decreased fetal movements, we have to have a protocol-based approach, and that protocol is also available on that paper, which has been published by Indian Society of Community Medicine. So we can get it on the net, and we can have that protocol pasted in our hospital. This important information which we need to pass on to our patient is sleep position, because women should be informed that after 28 weeks of pregnancy, going to sleep on their back is independently associated with late stillbirths. Going to sleep on the left or right side can reduce stillbirth by 5.8% in every pregnant woman after 28 weeks. Very important, and I was really happy to know. I always feel that the speaker is benefited most than the audience, because we go through many papers, we go through many references, and in one of these important references, I came to know that this itself is an independent risk factor for the late stillbirths. So ultrasound assessment, of course, in second trimester is related for the biometry and anomaly scan. And we have beautiful ISWA guidelines for performance of routine mid-trimester fetal ultrasound scans. We need to go for biometry, which is very important, proper biometry along with the anomaly scan. In the second trimester also, we need to look for the uterine artery Doppler as a screening for fetal growth restriction or preeclampsia. And again, I want to reiterate that the uterine artery notch is not being used at all. It is obsolete now, and we use only mean uterine artery PI, that too in percentile. So no single measurement is acceptable. When you get a report of right, left uterine artery, calculate it mean, and if it is not mentioned in percentiles, you can use that various charts available on net and put that in the graph and get which percentile that belongs to, because this is going to help us to monitor these patients. So in second trimester, we have to look into fetal heart in all scans, and it has been recommended in that paper that it has to be, fetal echo has to be recommended for high-risk patients. But we all obstetricians know that many a time there is no risk factors for a pregnant lady and the baby is diagnosed as congenital heart disease. So the most common congenital abnormality which is seen is the congenital heart disease, and that is commonly seen in low risk population. So my passion is always to motivate obstetricians to look into fetal heart, because always the obstetricians will give the reason of time constraints, but believe me, it's only a clip of 5 seconds which is going to screen for the fetal heart, and if we put the real efforts in a proper position. So this is done by ISWA's segmental sequential analysis, which includes 5 planes, which are very, very easy and can be captured in 5 to 10 seconds only if the spine is in posterior position. So we can start with situs, then 4-chamber, LVOT, then 3-vessel view and 3VT. So if at all any abnormality is seen, it's like completely mathematics. If this is 4-chamber view, this is checklist, this is 3-vessel view, this is checklist. If something is not seen, refer. You need not go in the details, but definitely you have an opportunity to learn, to look into fetal heart and save many more lives. Fetal monitoring in second and third trimester also includes symphysiofundal height, where the ultrasound facility is not available. So various intergrowth charts are available, WHO charts are available. But remember, we have to exclude pregnancies with multiple fibroids, polyhydramnios, or high BMI, or fetal growth restrictions, because that can be inaccurate. And that also symphysiofundal height, we can train our paramedical staff, and that also has to be marked in or put in this percentile chart, where we can see what these are the different percentiles and the red marks. These are, it should not go beyond this, or it should not fall below this line. So these are the red marks, and even paramedical staffs can also mark out if there is any discrepancy in this symphysiofundal height and the gestational age. In third trimester, the growth scan in the third trimester is advised preferably between 35 to 36 weeks for the biometry and estimated fetal weight, and also for late developing fetal abnormalities. Estimated fetal weight is more sensitive than fetal AC for the diagnosis of fetal growth restriction. But this is as per the Society of Stillbirth Society of India. But personally, I feel, as per my experience, that we should screen for FGR around 32 weeks of pregnancy, because 32 weeks is the day, mark where we can divide these FGRs into early FGRs and late FGRs, and we need to monitor the growth and classify them. So when we see that the gestational or estimated fetal weight of the baby is less than 10 centile, then we need to put a Doppler. We cannot ask, or we cannot wait for Doppler. So, but we have to do Doppler study and see how are the Dopplers. I mean, umbilical artery Doppler, uterine and MCA Doppler. So, if Dopplers are normal, though the fetal weight is less than 10 centile, we have to classify them as small for gestational age. And if estimated fetal weight is less than 10 centile, if Doppler is abnormal, we have to classify it as fetal growth restriction. But if fetal weight, estimated fetal weight is less than third centile, irrespective of the Dopplers, this baby is classified as FGR. And here is the role of following or see the growth trajectory. We need to have growth charts by our fetal medicine specialist or by our sonologist with us. That will help us how frequently should we monitor. Every time we cannot, very difficult to send these patients every visit to a fetal medicine specialist. It's better for obstetricians to learn about the proper biometry and then Dopplers and follow our own babies and take the action in due course. So optimal standards for high risk mothers. So mothers with risk factors must be offered serial growth scans and ultrasound, fetal biometry, and estimated fetal weight has to be done. Doppler study should be initiated from 24 to 20 weeks of pregnancy for the surveillance of FGR. That it is level 2 evidence and grade B. It's a very high evidence. So here we can see this baby as growth is falling below 5th centile, but still there is rising. Never it has been plateaued. So this is the importance of following this baby. So I'm not worried as long as this estimated fetal weight is increasing. So though it is below the 5th centile, we need to be little more cautious. We have to ask this lady about the strict fetal movements and strict follow. Whereas here we can see the growth was normal from second trimester, but suddenly in third trimester, around 32 weeks, the growth is falling. So this is how the late developing FGR is picked up, especially around 32 weeks of pregnancy. The major 3 concerns for this is we need to see is the really baby has got FGR or it is a SGA baby, and how long can we prolong this pregnancy. So because there is a risk of fetal death, we don't know if we don't follow the patients properly. These are the patients which are the main causes for the fetal intrauterine fetal deaths. So we need to monitor them, have their proper surveillance, and we need to decide when should we really intervene and when should we deliver the baby. So what are the problems in early and late FGRs? It is very important because in early FGRs, we see that 20 to 30% of the fetuses will have early FGRs, but problem is easy diagnosis, but problem is management because it's far from the term. So placental disease here is severe. It is highly associated with preeclampsia or placental insufficiency. Hypoxia plus systemic adaptation has occurred. Fetus is immature here, but it has got high tolerance for hypoxia, but there is a very high mortality. Whereas in late gestation, because we are nearer the term, we can take out the baby if we diagnose FGR, even though late. So 70 to 80% of the fetuses fall in late FGR categories, but problem is for diagnosis. Here, the placental disease is occurring beyond 32 weeks, and it is really relatively mild. It has got low association with preeclampsia. Here, there is hypoxia, but here central CVS or cardiovascular system adaptation can occur or cannot. So mature fetus is here a little bit mature, and that is why we use biophysical profile for these patients in late FGR to decide for the delivery. Whereas in early FGR, biophysical profile is not useful. It is the ductus venosus, which clearly tells us about the systemic adaptation. So this is how we need to clarify. I mean, we should be very clear about the early and late gestation FGRs. So when we see a fetus with small biometry, and if the anatomy or anatomy is abnormal, then there is a chance of aneuploidy or syndromic association or viral infections. If amniotic fluid is either decreased or increased, again chances for aneuploidy, various syndromes and infections. If umbilical artery Doppler is increased with less diastolic flow or absent or reduced diastolic flow, MCA Dopplers are changing, and then CPR has been less than 5th percentile, then there is a possibility of FGR due to placental insufficiency. And despite of that, if the fetus is small and everything is normal, then we need to repeat examination after 14 days. And if Doppler is normal, then it is the small for gestational age babies, because this is going to help us to decide the time of the delivery for this patient. This is a very good reference chart which helps in monitoring and timing of delivery of low-risk mothers with FGRs, where we can see that if AFW is less than 3rd centile with normal Doppler and adequate Likert, we can have weekly follow-up. Ultrasound we can offer them every 2 weeks. Never do growth monitoring within 2 weeks, but because there can be chances of errors. So we need to wait for 2 weeks to see how much baby has put on the weight. Then Doppler we need to offer them weekly, CTG or biophysical profile, and delivery by 37 weeks. So this is how this chart is going to help us. We can keep it as a reference chart on our table and decide, and we can show it to our patients also that this is the standard guideline, and I now need to intervene. The time has come. Apart from that, maternal perception of fetal movements in 2nd and 3rd trimester. So count until 10 distinct fetal movements are perceived in about 2 hours. We all tell to our patients, count for fetal movement for 1 hour, 3 times a day. But overall, a decrease in fetal movement is more predictive of adverse outcome as compared to that of a specific number of kicks. We ask patients how many kicks and all, but then overall decrease in fetal movements, we should never be ignorant about that. So we should tell the patient, make her educated that she needs to monitor the pattern of her fetal movements. So qualitative decrease in fetal movements, non-reassuring kick counts definitely mandates for further testing. So we know that mindfulness, whatever we are doing with complete concentration, and that is called mindfulness, meditation and all is coming up. But now this concept has come, mindfetalness. It is defined as being aware of the quantity and quality of movements of the fetus instead of maintaining the fetal count. So the mother should be mindful about her fetal activity. We need to educate her. Decreased fetal movements are associated with increased risk of stillbirth and adverse pregnancy outcomes like preterm labor, fetal growth restrictions, small for SJ babies, congenital abnormalities, and fetal-maternal hemorrhage, especially if recurrent episodes of decreased fetal movements are described by the mother. So in mindfetalness, we need to tell her that she has to monitor daily for 15 minutes, see that baby is awake, lie on left side and focus on the strength of the movement, character of the movement, and frequency. Need not count it. But this is very, very important. We have to educate our patients about the mindfetalness. So Stillbirth Society of India also has given this chart as mindfetalness is a way to connect with your baby. We can get it printed and paste it in our waiting rooms and educate our patients. What is this mindfetalness about? So if the patient comes with decreased fetal movements, this society also gives us the stepwise protocol for management of this decreased fetal movements, along with the detailed history, previous antenatal records, high-risk factors, clinical assessment, and everything. Then we have to follow the protocol and ensure that this is not recurrent. And then If at all it is recurrent, then advise the patient according to the further investigations. So recurrent decreased fetal movements at more than 38 weeks of pregnancy, we need to deliver her by induction of labor. But at 37 to 38 weeks of pregnancy, if she comes with recurrent decreased fetal movements, we have to take her informed consent for induction of labor and then deliver. It is for better medical legal purpose. So after that, after this antepartum monitoring, it is the monitoring during labor, which is very, very important. It starts with intermittent auscultation, periodic checking of heartbeats with Doppler or Pinard stethoscope for low risk pregnancies, or electronic fetal monitoring. Or we need to be completely aware of this about interpreting the CTG traces. Nowadays, we are getting it on our mobiles. We need to train our paramedical staffs what are the reassuring features and non-reassuring NSTs, and then because this is going to help us for the proper intervention at proper time. So intervention strategies like maternal positioning, till you reach the hospital, you can advise your staff about these intervention strategies and expedite the delivery, maybe by cesarean section or by other operative deliveries. So mode of the delivery in early FGR and late FGR, I'll not go into detail because the talk is not related for the FGR, but the prevention and best practices to prevent the intrauterine fetal death says ensuring all antenatal appointments are met with regular growth scans is very, very important. And the important message is that not a single scan is acceptable. Not a single scan will help you assess the growth of the baby. Not a single scan will rule out all the anomalies. So we need to have the serial growth scans and serial scans which are needed for proper monitoring of and preventing the intrauterine fetal deaths. Education about this to the mother herself, her family, and our staff is very important. Our staff also should not take it lightly. So we are very busy in our OPDs. We just कैसा है फिर रह के घूम रहा है क्या baby इतना ही पूछते निकल जाते. But then we never, many times we never listen to her answer also. So our staff should be trained for asking, then monitoring, and then noting it down, document the DFMR or daily fetal movement record is normal, count is normal or not. So we have to train our paramedical staffs. Then risk stratification should be done and better preconceptionally or at least at the first visit. So these are various ultrasound findings which we can because it is the ultrasound which is going to diagnose this as an intrauterine fetal death. So it can be absent fetal heart rate, absent fetal movements, occasional findings like overlapping of skull bones, Spalding sign, or gross distortion of fetal anomaly. We can have soft tissue edema, then features like hydrops, echogenic amniotic fluid. So these are possible ultrasound findings. We need to document, have a picture of that before we induce or intervene for these patients. So in ultrasound, we need to be very thorough about the biophysical profile because it is the obstetrician who is going to decide the time of the delivery. So we need to be thorough with the biophysical profile. We all know that the normal biophysical profile is 8 to 10. And if the score is 6, it is called equivocal. And if score is 4 or less, it is really to be taken seriously. So the modified biophysical profile includes NST and which is responsible for the acute causes like placental abruption, cord accident. So that time the NST will pick up these acute changes, whereas the amniotic fluid is going to pick up the chronic changes. Because of chronic placental insufficiency, there will be less amniotic fluid, and together they can give us a clue. If something is, if modified biophysical profile is abnormal, then definitely we can extend our test for biophysical profile or contraction test. Non-stress test and all, I'll not go into details because every one of us know contraction stress test or electronic fetal monitoring. At least it has come to India, but I'm not very well aware of that, where it is available. I'm not using that. So to summarize, stillbirth prevention relies on a combination of maternal awareness, regular clinical screening, and accurate interpretation of monitoring data. It is very important. Final thought is that timely action based on fetal surveillance is going to save lives. And important message is fetal placental autopsy and genetic testing is must And if the patient or the family refuses, we have to document it, the refusal consent. So I'm really thankful. I had to rush because of, and I'm really sorry for the inconvenience created, Dr. Monica. I'm really sorry, sir. Thank you so much. It's a very good article, good reference, antenatal care bundle for preventing stillbirths by Stillbirth Society of India.
Thank you, Dr. Megha Kamlapurkar, for the excellent talk. It was a really wonderful talk and an eye-opener. You have updated us about everything that is available. Thank you very much. We all know that stillbirth is a catastrophic and dreaded complication for the patient and her family, and also has consequences for the obstetrician. And it's an important cause for medico-legal issues as well. So this is a very important topic, which we need, even though most of us know about fetal surveillance, we need to refresh and relearn and update ourselves regularly, because it's so important. And we can land in trouble if we are not updated. And I think Dr. Megha has done full justice to this topic, and she's really disseminated knowledge in a wonderful way. Congratulations, Dr. Megha. Thank you, Dr. MC Patel, sir, for the opportunity. Thank you very much.
Can we have Dr. Raju Giradi sir or Abhijit sir for their comments?
Yes, ma'am. Ma'am, indeed, it was a very privilege to learn from ma'am yet another time. And this topic was so wonderfully covered, and your session was had so much of insights, and always it was backed up with such depth of knowledge and clarity, and many new things were told in this session. Thank you, ma'am, for sharing your expertise, your experience, and a practical approach, which will definitely help us all in improving our day-to-day clinical practice. Thank you, Megha, ma'am. It was a privilege to listen to you once again. Thank you, ma'am.
Patel sir, for your comments, sir. Hello. Patel sir, are you there? Okay, let's start with the panel discussion, I think. Can I request Dr. Shatabdi Dey to please start with the panel discussion now?
Yes. Thank you, Monica. After those three engaging talks, we now move on to the panel discussion. We have a very interesting panel discussion coming up today. The moderators of the panel are Dr. Ramadevi Vani ma'am and Dr. Sridevi Medgud ma'am, with experts being Dr. Neelam Agarwal ma'am and Dr. Tamkin Khan ma'am. Can I have the CVs, please? Dr. Ramadevi Vani ma'am is currently working as an associate professor at Kahed's JN Medical College. She has worked as a consultant in a tertiary ministry hospital in Kuwait between 1996 to 2016, and her special areas of interest are high-risk pregnancy, adolescent gynecology, infertility, and endoscopic surgery. Welcome, ma'am. Next CV, please. Welcome, ma'am. Our next moderator is Dr. Sridevi Medgud ma'am. Ma'am has over 13 years of practice in high-risk obstetrics, gynae endoscopy, and advanced obs-gynae ultrasound. She has been the Joint Secretary of BLOGS as well as the Secretary of Scientific Society between 2015 to 2017. And she has been a resource person at various national and state conferences. Welcome, Sridevi ma'am.
Thank you, ma'am.
We have Dr. Tamkin ma'am as our expert. Can I have the CVs? And Dr. Neelam Agarwal ma'am. Yes, Dr. Neelam CV. Dr. Neelam ma'am is the professor at MMC MSR at Sadopur at Ambala. She also is a professor, superannuated professor at PGI MBR at Chandigarh, and the founder, president of Stillbirth Society of India, has been the past president of the Indian Menopause Society. Welcome, Neelam ma'am. Can I have the next CV, please? Our next expert is Professor Tamkin Khan, ma'am.
Ma'am has over 30 years of teaching experience. She has guided around 45 MD/MS to students and PhD thesis. Ma'am is also one of the founder secretaries of the Stillbirth Society of India. She has established the DBT GOI Nidan Kendra for genetic testing and counseling. Her special areas of interest are fetal medicine and high-risk pregnancy, medical education, and medical humanities. Welcome, ma'am.
Thank you. Thank you so much.
Welcome, ma'am. We have 6 panelists with us today. First is Dr. Shuguna Kumar Veera, ma'am. She is the past president of the Vijaypura Obs-Gynae Society. Next, we have with us Dr. Sayeeda, ma'am. Ma'am is an associate professor at BLD Shri B.M. Patil College, Vijaypura Society. Next, we have Dr. Shweta M, ma'am. She is the secretary of the Mandya Obs-Gynae Society. Then we have Dr. Rachana, ma'am. Dr. Rachana is the secretary of Tumkur Obs-Gynae Society. Next, we have Dr. Shailaja MN. Dr. Shailaja has been the past secretary of Tumkur Obs-Gynae Society. And we also have Dr. Abhinetri Patil. Dr. Abhinetri is the past secretary of Raichur Obs-Gynae Society. Now, over to the moderators. Looking forward to a good panel discussion. Yes.
Good evening, everybody. Can you see our slides, please?
Ma'am, not here.
Is it visible, ma'am? No. Is it visible now?
I think it will be.
1 second.
Not yet, ma'am.
Not yet. 1 second.
Yeah.
Now, ma'am?
Yes, ma'am. You have to make it full screen. It's visible. Yes.
Okay, fine. We'll do it. Yes, I think you can minimize. Good evening, everybody. At the outset, I would like to thank Dr. Patel, sir, for giving us this opportunity to moderate the panel discussion on a very important topic, that is ending preventable stillbirths. We all know that this is the most neglected tragedy in global health. There are several initiatives being done by all nations in the world. And the one important initiative is the Every Newborn Initiative, which is led by WHO and UNICEF. And it aims at preventing, ending the preventable. Is it clear? Am I audible, please?
Yeah.
Yeah. It aims at ending the preventable stillbirths. The aim is to reach at least 12 or fewer stillbirths per 1,000 total births in all countries by 2030. So actions are needed to accelerate progress by threefold if we wish to reduce the stillbirths. We all know that fetal growth restriction, hypertension, and infections are the main drivers of stillbirths. And early detection of risk factors and high quality antenatal care can definitely reduce the stillbirth rate. Before I begin, now after this lucid lecture by Dr. Megha, one would probably feel that the first half of our case discussions are based as questions on her lecture. But because these are very important, it is coincidence that our case studies almost mirror what she has already spoken. Before that, before I start the first case, I would like to welcome our esteemed expert panelists, Dr. Tamkin ma'am and Dr. Neelam Agarwal, and also, our esteemed experts actually for the panel, and also panelists, Dr. Shailaja, Dr. Suguna, Dr. Abhinetri, Dr. Shweta, Dr. Saida, and Dr. Rachana. Now, without much ado, let us start with our case studies. Case 1 is a Mrs. A, aged 28 years, a primey, 28 weeks pregnant with normal antenatal investigations and no apparent obstetric risk factors. She has come for an antenatal visit. She is worried as her friend, who had no obstetric complications, suffered a stillbirth at 38 weeks of pregnancy. She is keen to know if there are any preventive measures to be taken. Dr. Shailaja, would you like to answer, please?
Madam, Dr. Shailaja is there in the, she's there. She has joined or not?
I'll just check once.
Because I did not see the name.
Can anybody else in the panel? Would you like to answer?
Yes, ma'am. I'm Dr. Rachna here, ma'am, from the same society here, ma'am.
Okay.
So I just want to reassure the patient first. I want to alleviate her anxiety. Tell her that I will go through her history and tell her that she doesn't have any risk factors, but she needs to be aware of the symptoms that may lead to such conditions. Such as I will tell her that she has to keep a proper fetal kick count. She should also, I would examine her, tell her that the growth is adequate as per examination, and I would tell her or educate her about the fetal kick count, its importance, and if how she has to sleep, that she has to sleep in her left lateral position. And she should report to hospital if there is any sudden increase in weight gain and there is any pedal edema, increased edema, which is not decreasing on waking up in the morning. All such warning signs I would like to tell her. And I would also tell her on a proper carb, high fiber diet, and then reassure her and tell, I'm sure if she has any addictive abusive substance she's using, excessive caffeine she's using, I would inform her not to use those also.
And
yes,
and
please.
also she should report if there is decreased fetal movement,
Yes.
labor pain, reading PV. And some patient they wait for the labor to onset. They beyond the expected date of delivery, they still may be waiting. So we have to tell them, they have to report to us. And to reassure her, one USG, it is better to do.
Yes, absolutely. And regarding this fetal kick counting, already Dr. Megha has spoken in detail. Although, because it is known that decreased fetal movement, women who present with decreased fetal movement, they are at an increased risk of adverse perinatal outcomes. Although there is no specified threshold limit, it is important that the mother appreciates what is because each baby has a unique pattern of movements, and the mother should appreciate that. And there is no need to keep a count exactly like number 10, counting Cardiff 10 or 10 movements in 12 hours. This is not necessarily very necessary. Now, secondly, if this fetal kick counting, we should always trust the mother.
Yes.
If she is coming for the second time again as decreased fetal movements, she should be put on high-risk surveillance after 28 weeks. And this already Dr. Megha has how to manage those cases. Dr. Megha has very lucidly told us. That is, we need to check the fetal heart rate, look for the size of the uterus, a CTG to reassure, and also to exclude fetal compromise, ultrasound, and when to deliver, she has already spoken about. Now again, as on parallel with the kick count, what is now of late coming up, as she already has spoken, is about mind fetalness. This is one systematic way of observing the fetal movements, and it's a method for raising women's awareness of fetal movements. It's a structured 15-minute daily practice, as already explained in detail before, where a pregnant woman lies on her side when the fetus is awake and monitors the character, strength, and frequency of the movements, but does not count each movement. Now, this study, which was a large cluster randomized controlled trial involving 40,000 women, it showed that introducing mind fetalness, where the woman appreciates the pattern of her baby's movements cautiously, in maternity care, it decreased cesarean sections but had no effect on the occurrence of Apgar score less than 7.
Sleeping.
Now, would you like to, any one of you, talk about significance of lying on the side position, please?
Yes,
or sleeping on side?
Yes, supine position. Some people have the tendency to sleep in the supine position. Actually, there is compression of the inferior vena cava showing decreased blood flow in the iliac arteries and also the uterine blood flow. causing fetal hypoxia. So this may be one of the cause for stillbirth. So we have
Yes.
to tell the patient to sleep left lateral or either lateral position, it's okay.
Absolutely right. This is an extremely important advice that we need to give to the mothers when they attend for the antenatal care visits, because this is such a simple thing, easily understandable to mothers, and has a very important impact on the outcome of babies. As already told, it is known to reduce the stillbirth rate by almost 6%. Experts, Madam Tamkin and Madam Neelam, would you like to add anything else regarding, for low risk women, what other actions need to be taken to reduce stillbirths?
Yes, I think we start right from the pre-pregnancy time, having an ideal BMI if she is overweight, because that is also one of the risk factors. And then there is the risk from smoking or any other addiction. And many a times we forget the passive smoking that is happening all the time. She's staying from low socioeconomic group, staying in a room 8 by 10 feet, and the whole night the husband is smoking bidis. So lots of passive smoking is going in there. So these are two very important things. Then apart from that, the latest, data from WHO and UNICEF says that, any personal problems that she's facing, or she's in a conflict zone or a disaster zone, all this puts her into the high risk category, as well as the environmental pollutants, as well as domestic violence. And that is always associated with alcoholism in the husband. So all these we have to find out and take history, because these will not be apparent. And only when we learn to take history in a very sensitive manner, then only she will share something very private with us. So there's a triple causation theory, which says that it is not just single, because you must have seen, everybody sees that a patient with insulin dependent diabetes, she delivers and she doesn't have any problem. And a woman with mild gestational diabetes, mild IHCP, and she lands up with a IUFD. So the triple causation is that there is some genetic problem, there is some environmental problem, or some acute event, like she's sleeping on her back. So all these combine together, and that ends in a intrauterine death. So that we have to keep in mind.
Thank you so much, ma'am. Dr. Neelam, would you like to add anything else? So we go on to the next case now, the second case. This is a case study on fetal growth restriction, which has been very fantastically, clearly explained by Dr. Megha just a few minutes before. Now, she is a 30-year-old primey, spontaneous singleton pregnancy, attended OPD at 30 weeks for routine antenatal checkup. She had no complaints. Her BP was 130/80, symphysiofundal height measured 26 centimeters. Alarmed by this, ultrasound was done, which showed both abdominal circumference and estimated fetal weight at 6th centile, with uterine artery PI more than 95th centile. Looking into her case papers, it was known that the gestational age was confirmed by dating scan. NT scan at 12 weeks showed a normal NT. Dual marker showed a PAPA less than 0.4 MOM and beta HCG of 1.1 MOM. Not known to have hypertension or diabetes. There is no history suggestive of any infection. So what is your diagnosis? Dr. Suguna, would you like to take on this?
Yes. Actually, the age is 30 weeks, but the symphysiofundal height is 26 centimeters, so 4 centimeter less it is. And so below 10th percentile growth, 6th percentile it is. So it indicates fetal growth restriction, and this is early onset fetal growth restriction. And the umbilical artery PI is also more than 95%. It indicates this patient has more chance of getting PIH. And her investigation, other dual marker PAPA is less than 0.4 MOM. This also indicates that this patient should actually have a MOM of more than 0.5 but this is less than 0.4. So it indicates that this patient has increased risk of placental insufficiency and intrauterine growth retardation and PAH. Beta HCG is fine. So this is early onset fetal growth restriction.
Absolutely correct what you have said. This is early FGR, and as per the
Madam
definition,
has discussed in detail. Megha
yeah.
Madam. Yeah.
Yeah. So as she has already said, we call it as early FGR if the AC or EFW is less than third centile, or umbilical artery absent, or we have less than 10th centile with uterine artery PI of 95th centile, more than 95th, or umbilical artery PI of more than 95th.
Yes.
Now it is extremely, we all know that it is this fetal growth restriction is an important preventable cause of stillbirths. So it is extremely important that at the booking, that is in the first trimester, when the mother comes for the outpatient clinic for antenatal care, we need to take a detailed history and find out if she has any high risk factors for fetal growth restriction. And if so, she needs to be put on a higher surveillance than the low risk mothers. So as we all know, the high risk factors for fetal growth restriction are maternal medical history of chronic kidney disease, hypertension, autoimmune disease, APLA, complex cardiac disease, previous FGR, hypertensive disease in the previous pregnancy, previous SGA stillbirth. In the current pregnancy, PAPA less than the 5th centile, AFP more than 2 MOM, single umbilical artery, echogenic bowel, etc. Now, if there are more than 3 moderate risk factors like previous SGA, previous stillbirth of appropriate for gestational age baby, birth weight, or current risk factors like current smoker, misuse, drug misuse, woman more than 40 years at booking, if she has had a gastric bypass, these all come under as moderate risk factors. So we need to spend enough time in the first booking visit to take a detailed history and to see if she is having any risk factors to develop fetal growth restriction. Now, how will you monitor this patient? We now know that we know that she has early fetal growth restriction, and how do we monitor?
So she requires intense serial surveillance because we had to balance the risk of premature birth and also the intrauterine fetal death. Both risks are there. So I advise weekly Doppler of the umbilical artery, MCA, and fetal growth monitoring every 2 weeks to see fetal surveillance twice weekly, and daily fetal monitoring every 2 weeks we have to do, madam.
Yeah,
to see the fetal growth.
Yeah, for growth. Otherwise, it is weekly Doppler because because the uterine artery, umbilical artery PI is more than 95th centile in this case. So now she missed her one appointment and comes back at 32 weeks of pregnancy. Her BP is normal, no other new risk factors, and ultrasound shows absent end-diastolic flow. So which indicates severe placental insufficiency. So
This
how would you
patient
like to
requires
manage?
admission now. She should be admitted, and you have to monitor her daily, and she is for delivery. So we have to see that we have a good NICU with the fetal medicine specialist available. If you don't have, better to transfer to that center where availability is there. And this patient may develop preeclampsia. We have to monitor for that. And Doppler and biophysical profile study every 2 to 3 days, NST daily, and we have to monitor the daily fetal count. Tell the patient, because we are going to deliver her, we have to give antenatal steroid. Magnesium sulfide has neuroprotective. If the monitoring is fine, we'll continue up till 34 weeks and deliver her by cesarean section. In between, if she deteriorates, if there are any changes again occur, then we have to deliver her immediately. Like a ductus venosus, if comes, we have to deliver her immediately.
Okay. Excellent. Usually, when it is absent end-diastolic flow, usually the ductus venosus remains normal. So this would be enough for the umbilical artery Doppler is being continued. Just to add a note, what they have told is perfectly fine. Regarding corticosteroids for the fetal lung maturity, what is available in India, the betamethasone, what is available in India.
Both are available, ma'am. But our betamethasone is not.
It's not.
Yes, both are available, but the betamethasone, what is available in India, is not a combination of both the acetate and phosphate. It is only phosphate. So it is very important that we use dexamethasone in India instead of betamethasone. And dexamethasone, of course, is economical when compared to the betamethasone injections, and they should be given at 6 milligrams 12th hourly, 4 doses, as all of us know.
And I just want to add, ma'am, here maternal risks should outweigh the fetal risk, basically, because if mother is preeclampsia, definitely she also is at risk.
Yeah.
So
In
both you
this
should monitor.
particular case, yes.
Yes. Yeah.
In this,
In
BP was
only
normal
this
in this
particular
case.
I have
case,
mentioned already,
Mm.
assessed, but what we do is, of course, we do assess for preeclampsia, but BP was already normal in her case.
Okay. And here we are buying time only for fetal lung maturity.
Yes, it is mainly for the maturity. It shouldn't happen that we get a preterm baby out and the baby ends up as neonatal mortality. So we need to balance properly and see to it that the baby should be fine, and at the same time the maturity also should be attained. So that balance is very important, and Doppler study helps in doing that. Now coming to case 3. Dr. Abhinetri, would you like to take this case, please? She is a 32-year-old primie, a low-risk pregnancy with a regular antenatal checkup, attends OPD for routine checkup at 34 weeks. Her BP is 120/80, symphysiofundal height is 30 centimeters. Ultrasound, again, because of this discrepancy in the gestational age, confirmed gestational age and the symphysiofundal height, ultrasound was done. Estimated fetal weight was at 5th centile. Umbilical artery Doppler was 86 centile. MCA was 7th centile. So what is your diagnosis? Dr. Abhinetri, are you there, please? Anybody else would like to take up this? The panelists, please. I put up this case of late onset fetal growth restriction. This is because in late onset fetal growth restriction, as all of us know, the placental insufficiency is less. So what happens here is that the umbilical artery Doppler usually remains normal. MCA, PI, if you take them independently, they may remain normal, but the ratio, that is the CPR ratio, if you do that, in this particular case, it was CPR ratio was less than 5. It was 4. So CPR ratio picks up subtle abnormality in the fetal well-being. So we need to do the CPR ratio for late onset to detect late onset FGR. Just performing umbilical artery Doppler, in this particular case, we would have missed late onset FGR. So again, late onset FGR is AC or EFW. After then, early and late, the gestational age dividing it is 32 weeks, and abdominal circumference or estimated fetal weight less than 3rd centile, or 2 of the 3 following, that is AC less than 10th, so EFW less than 10th centile, or a drop more than 2 quartiles or drop more than 50 centiles, CPR less than 5 centile, or umbilical artery umbilical artery PI more than 95th centile. If you have 2 of these 3, or just one single, that is EFW less than 3rd centile after 32 weeks, we diagnose them as late fetal growth restriction. In this particular case, the CPR was less than 5 centile. Now, how do we monitor this? A regular evaluation, again, for evidence of preeclampsia should be done. Biweekly Doppler along with biophysical profile. Here, because what is affected in late fetal growth restriction is that it is the brainstem which is affected here, because the mature brain is very, very sensitive to hypoxia. So we find changes in the biophysical profile in late fetal growth restriction. So she needs to be kept on the daily fetal movement count. And with this biweekly Doppler and the BPP, if they remain fine, then we can deliver her at 37 weeks. Abnormal CPR alone is not an indication to deliver the fetus before 37 weeks. We need to assess the woman if she has developed any new risk factors. If none of them are there, CPR alone, abnormal CPR alone is not an indication. I would just like to add one more thing here regarding the biophysical profile. We all know that these are the 4 components which are available in biophysical profile. The first 4 are which respond to the acute events, and the Likert volume is for the chronic event. Now, most of us may think that, oh, biophysical profile, doing this takes about 30 minutes and it's a really time consuming work. The biophysical profile is extremely important, and studies have shown that when you do the biophysical profile, most of the times you can finish it within 6 minutes. You need not do all the components here. If the baby is jeopardized because of hypoxia, the first thing to vanish is breathing movement. Then we see decrease in the variation of the CTG. So when you are doing an ultrasound, if you see breathing movement, and perfectly that rules out that baby is hypoxic or baby is jeopardized. So just following breathing movement while doing an ultrasound is an important aspect to monitor the baby. Now this, I just took it as this is a very simple chart, which is by Fetal Medicine Barcelona group, that is Professor Greta Cost. As you see, when in our case, there's late fetal growth restriction, it was only increase in the, it was abnormal CPR alone. So in that case, she comes under stage 1 and she needs to be delivered at 37 weeks. That's the second case which we discussed. That is the first case in growth restriction. She later developed absent end diastolic flow. That would mean she was at stage 2 FGR. And so there the plan would be follow-up every 2 to 3 days and delivery at 34 weeks. Now to our expert ma'ams, please. Your input regarding balancing outcomes in late FGR and early FGR, because especially the late FGR is responsible for a significant chunk of preventable stillbirths. So shall we go to the next case, please?
Okay. Ma'am, would you like to take this or shall we proceed? Are we audible?
Yes, ma'am, you are.
Okay. Yeah, right. Thank you. So we'll be going on to the next case. Here we have a case, Mrs. ABC. She's 35 years, gravida 3, para 2, living 0, and she's currently around 8 weeks. She's come for a routine ANC and her BP is found to be normal. And her obstetric history is suggestive of a bad obstetric history where she has had a previous preterm delivery which was induced at 26 for severe PE and severe FGR. And the second delivery also she has ended up with a preterm for IUFD due to abruption at 32 weeks. Now she's concerned about this pregnancy. So how will you manage her further? She's currently around 8 weeks. So anybody who's taking this, ma'am? Dr. Rachna?
Yes, ma'am. She probably, we have to suspect APS, ma'am, antiphospholipid syndrome.
Okay.
So I would put her on prophylactic aspirin, 150 milligram at bedtime. And I would do an early ultrasound, 8 weeks ultrasound. I would like to see her uterine artery PI and 12 weeks, at 12 weeks. And I'll keep a close monitor on her. I may start her on low molecular weight heparin also. Though it is not in the recommendation.
No.
If it is proved it is APS, then I would like to start.
So I would ask you, when do you want to initiate aspirin? Is it after you do the first trimester ultrasound or as soon as the cardiac activity appears?
Cardiac activity is seen.
Yes.
As early as 8 weeks, I would like to start her on.
Yes.
Then I would monitor her BP. I would tell her the importance of her BP monitoring. And would do an early growth scan at 26 weeks itself. I would start monitoring her regularly. Serial growth monitoring would be the best for her.
Yes, ma'am. So considering this serial monitoring of growth, we would do an anomaly scan between 18 to 22 weeks. And after that, maybe 28, 32, and at 36 weeks. would be the serial growth monitoring, which is advised for this patient. Would you like to elaborate anything on the serum analytes or the prediction of adverse outcomes using the PLGF, ma'am?
Our usage is we are not using at our center. So
okay.
It has a 50 nanogram cutoff that if it is less than that, it's found to be at low risk or something. I'm not sure of that.
Okay, ma'am. Thank you so much. Okay. What would be the probable cause of her bad obstetric history? I think you already answered this. Yes. Yeah. So you should consider evaluating her for antiphospholipid antibody syndrome.
Ideally, she should have come in interval period itself, ma'am.
Yes. Yes.
Though my intervention is only during pregnancy, I would like to make a diagnosis. After the history, I would like to investigate her 6 weeks after the last event, and 2 investigations 12 weeks apart I would have done. Just that is the modified Sapporo's criteria is what is used now, where presence of any beta-2 glycoprotein, lupus anticoagulant, and then she should have an event of thrombosis. It can be arterial, venous, or any small vessel thrombosis, and or present history of any fetal loss, which is a morphologically normal fetus after 10 weeks, and any stillbirth which was less than 34 weeks of gestation, and 3 consecutive unexplained miscarriages prior to 10 weeks. This is the modified Sapporo's criteria that it should have all this.
Okay, thank you. Yeah, so the diagnostic criteria includes clinical as well as the laboratory criteria. So at least 1 clinical criteria and 1 of the laboratory criteria is necessary to make a diagnosis of APS. Yeah, so she has continued her pregnancy. Now, what else would you like to consider thinking of her as a case of antiphospholipid antibody? Any other pharmacological agent you would prefer adding?
Yeah, low molecular weight heparin would be my choice, ma'am. I would give her 40 international units daily.
Yes. Okay.
I would start at 12 weeks.
Yeah, so the preferred drug is low molecular weight heparin, and in women who are not economically well placed or who are not economically doing very well, you can consider a lower cost option like a unfractionated heparin in them. And the other anticoagulants are not preferred in pregnancy. So what other additional precautions are needed for this patient to manage this pregnancy?
Yeah, the thromboprophylaxis should continue, ma'am, for her at least till 6 weeks.
For at least 6 weeks.
And also you should continue to monitor her blood pressure, and she should be informed that she may continue to become a hypertensive patient. All this counseling should be done to her.
Okay. Can you elaborate on anything for the recurrent risk of abruption or any screenings which are available for that? So currently there is no test to screen or predict abruptio placenta. Okay, so she has to be told that after 32 weeks or after 34 weeks, preferably she stays closer to the healthcare facility where she wishes to deliver. And in case of any suspected signs of abruption, then she should be immediately rushed to the hospital. Okay, since there are no other predictions which are available. So despite being on aspirin, despite being on anticoagulants, still there is going to be a risk of abruption in this patient. I would like to have some insights from the experts, if they are there. Okay, we'll move on to the next case. Yeah, so coming to the case 5, we have Mrs. H. She's 32 years. She's a gravida 2 para 1 living 0 with 34 weeks of pregnancy. And during her routine screening during her antenatal visit, she was found to have GDM at 24 weeks of gestation. And currently she's on insulin for her diabetes since her diagnosis, that is from 24 weeks onwards. Her initial HbA1c at diagnosis was 8, and the latest one is 7.8, which is done 1 week back. Her obstetric history is also significant, where she has had a previous full-term delivery of a 4 kg fresh stillbirth 2 years ago. Now she is worried about her delivery and she's come at 34 weeks of gestation. So anybody would want to answer this?
Ma'am, for this patient,
Yes, ma'am,
hello.
please. Yes, ma'am.
Ma'am, for this patient, as this is a previously she has lost one baby, ma'am, and previous baby was also 4 kg baby, ma'am. So it
Yes.
clearly indicate that that time also she had macrosomia, and might be that time it was undiagnosed diabetes. But this
Yes.
time, as she is a GDM case and her HbA1c levels are not under control, ma'am. For the tight glycemic control, we should have the HbA1c level should be less than 6%. Already it is 7.8. So we have to tell her about the tight glycemic control, ma'am. And regarding the diet and the exercise and the insulin, we have to tell, ma'am. Regarding the diet, we have to tell her about take the complex carbohydrate, ma'am. And her diet should contain 3 meals and the 3 snacks. And each meal should have whenever she's taking the meal, it should have the complex carbohydrate and 20 to 30% of the protein. And when she's about the fat is 20 to 30% of the unsaturated fat she should take, ma'am. And the exercise is because if she control about the diet and exercise, it will indirectly control, it decreases the insulin resistance, ma'am. So she will have the proper glycemic control so that we can prevent the complication related to the diabetes like macrosomia. Again, this time also she is more prone for the macrosomia, preterm delivery or the polyhydramnios, ma'am. Regarding the exercise, we will tell her okay, every day for 30 minutes she should have a aerobic exercise, ma'am. And she should have for a week 5 days she should have, ma'am. Regarding the exercise, ma'am. And the insulin is she should take we should refer her to the endocrinologist every second weekly for the tight glycemic control, ma'am.
Okay.
And regarding we have to tell her about the daily fetal kick count, because we know okay, more of the diabetic patients they are prone for the stillbirth. So we should tell them about the glycemic control and the NST also we should do, ma'am, every weekly. And we have to consider the delivery once she is completed the 37 weeks, ma'am.
Yes, ma'am. Okay. Yeah. So what should be her target glycemic controls? She's already 34 weeks now. So her target glycemic control.
Ma'am, actually, according to the ECOG, the fasting blood sugar should be in between the 70 to 95 milligram per deciliter, because less than 63, they are considering it as hypoglycemia. And the postprandial blood sugar, what we are taking after 1 hour and the 2 hours we are taking, ma'am. After 1 hour, it should be between the 110 to 140. And after the 2 hours, it should be 100 to 120 milligram per deciliter. And HbA1c should be less than 6, ma'am. This should be the tight glycemic control.
Okay. Right. So this helps to keep the fetal growth on whatever growth profile is required. And
Yes,
you can also predict macrosomia. So what precautions would you want to take to prevent the occurrence of stillbirth in this patient? She's had a previous vaginal delivery, which was 4 kg.
Yes, ma'am. Might be, ma'am, previously also she might have some complications. Because of that only the previous baby was FSB. So this time we have to do the serial fetal. First of all, we have to have a glycemic control, ma'am. Sugar level should be controlled. And we should have the serial monitoring, ma'am, regarding the baby's weight, the polyhydramnios, everything. Because as we know, they are again more prone for the macrosomia, ma'am. So if there is a macrosomia and polyhydramnios is there, again they are more prone for the intrapartum complication, ma'am. And if she is a macrosomia, so that with that we can take a proper decision, ma'am. Like more than 4 kg baby is there, so we should directly consider her for the section, ma'am.
Okay.
And sometimes if it is even the less weight is there, but still we doesn't know, okay, sometimes they'll have the CPD also, ma'am. So accordingly we have to manage, ma'am.
Yeah.
And one senior obstetrician, whenever, because she has previous loss and we are suspecting it as an shoulder dystocia, a senior obstetrician must be there, ma'am.
Yes. Yes. So one must predict shoulder dystocia. So despite the fetal weight being normal, still the bisacromial diameter and the deposition of fat over the shoulder area and the anterior chest wall is going to be more in infant of diabetic mothers. So hence, despite the head being delivered, despite the fetal weight being okay, not very large for gestational age, still you may anticipate shoulder dystocia. You have to anticipate shoulder dystocia in delivering diabetic mothers. So this was this is a very good study which was done recently in 2023. It is published for a clinical analysis of diabetes in pregnancy with stillbirth. And here they have seen that fasting blood sugar, the postprandial, the HbA1c levels, and the fetal growth, these are the independent risk factors which are associated with occurrence of stillbirths in diabetic mothers. Now going on to the next case, Mrs. R, she is gravida 2 para 1 living 0 with 10 weeks of pregnancy. She comes for antenatal registration. Her obstetric history is suggestive of a previous preterm delivery with a fresh stillbirth of 850 grams at 27 weeks due to spontaneous preterm. She is concerned of having another preterm delivery. So how would you counsel this patient and what would be the further management? Dr. Shweta, please.
Yes, ma'am. For this patient, we need to do serial cervical length monitoring because that might be the reason, and we should rule out infections also, bacterial vaginosis, and they will that will also cause preterm premature rupture of membranes, and it will lead to preterm deliveries. So, and the progesterones have a role actually. Micronized progesterones per vaginal insertion, it has shown the like benefits of prolonging the pregnancy. So then prophylactic cerclage can be done if the cervical length is less than 2.5 mm, 2.5 centimeters.
Okay. Yeah. So she has to be put on screening for preterm birth, that is mainly by a non-invasive or a minimally invasive technique of transvaginal measurement of the cervical length. Okay, so the NICE guidelines of 2018, they suggest that if the cervical length is more than 15 mm, okay, and if she has had a preterm birth or if there is any history suggestive of preterm birth, then the likelihood of her having another preterm birth within the next 48 hours is going to be increased. And if the cervical length is more than 15 mm, she's unlikely to have preterm birth. What about fetal fibronectin, ma'am?
Ma'am, if it is elevated, then the risk within 48 hours of she having preterm delivery will be increased, ma'am. So if it is negative, it is unlikely that she'll have preterm delivery.
Yes. So this is one test which has got a very high negative predictive value. That is, if the test is negative, then the woman is unlikely to suffer a preterm birth. But however, if the test is positive, then she should be offered further treatment. She should be offered further screening. She should be put on surveillance for detection of preterm labor. So this test is important to rule out preterm labor rather than rule in. So it's more important to have a negative test for fibronectin than a positive one. Right. What about micronized progesterone, ma'am? You already told this. Yeah.
Yes, ma'am. It has got a role actually, both like prophylactic cerclage or micronized progesterone. We did study at our center actually, PJ. So both have similar role only. So if the cervical length is normal in serial monitoring, then progesterones will only suffice. So no need to go for cerclage. It is also at the
What is the dose actually?
200 milligram, ma'am. 200 milligram is the recommended.
200 milligram per vaginal.
Because some prescribe 300, 400.
But
actually, for recurrent pregnancy losses,
it is 200 milligram.
For recurrent pregnancy losses and recurrent implantation failure, they use 400 mg TID, up to 400 mg TID, ma'am. Infertility specialists. For this set, we use only 200 mg.
200 mg.
Okay. So the ideal dose which is recommended is 400 milligrams per vaginally, and it has to be combined with the serial cervical length monitoring, preferable to start between 16 to 24 weeks and continue up to 34 weeks for prevention of preterm birth in cases of suspected or who are screened positive for preterm. Okay. Can anybody elaborate the role of cervical encerclage in preterm births?
This also prevents preterm labor. If the cervical length is less, if it is less than 2.5 centimeter.
Yes, ma'am. So wherever there is a cervical length which is less than 2.5 centimeters with a history of previous preterm birth, definitely a prophylactic cerclage is indicated. Or when there are 3 or more midterm losses or a single preterm birth, then it's also indicated to put a prophylactic cerclage, and it should be preferably offered in the first trimester after 12 weeks of pregnancy. Yeah,
actually,
after her NT scan.
prophylactic encerclage, we think it is very safe. So sometimes it happens that after cerclage, even the length is more than 2.5 centimeters, then there will be leak. So I had one
Yes,
patient. So then we did intraamniotic fresh frozen plasma and platelet-rich fibrin. Then it got sealed. So it's actually, I feel counseling the patients is very important before we go for any invasive procedures like cerclage and all. We should counsel them prior to cerclage so that they can have leak or some like adverse events can happen. So I had that experience.
Yes, ma'am. Thank you so much. So to summarize regarding the preventable aspects of preterm labor, preventive aspects of occurrence of stillbirths, it is important to sleep. The sleep position is important, which is an important modifiable risk factor to prevent stillbirths. Accurate dating of pregnancy, because we need to diagnose the late and early onset FGRs versus the small for gestational age babies. And a complete detailed maternal history at booking visit is a must to identify the possible risk factors for FGR. It's important to put the babies on monitoring whenever required using Doppler studies, and that also helps us to differentiate from SGA from FGR babies, and to optimize outcome using integrated fetal monitoring. And regarding the last 3 cases, to summarize, screening for preeclampsia is important, where we are going to use the uterine artery Doppler along with the PLGF, use of low-dose aspirin in high-risk groups, early referral to tertiary care center, increased surveillance in women who are at high risk for preeclampsia, and timely delivery. And screening for diabetes as per the guidelines. Some of the countries, they follow the HAPO, some of them follow the IADPHG. We follow DIPSI in India. So that is whatever screening test is available, it has to be done as per that. Then tight glycemic control in pregnancy and timely delivery for preventing the stillbirths. Then for preterm labor prevention, which contribute again a majority of the stillbirths, screening for preterm labor using transvaginal ultrasound measurement of cervical length. Then prophylactic cerclage wherever indicated, which has to be wisely chosen, versus micronized progesterone. Then tocolysis, if indicated, you can use tocolysis. Then antenatal corticosteroids, neuroprotection using magnesium sulfate, and very important is in utero transfer to tertiary care in preterm labor. So we have covered, I think, few aspects of preventable causes of stillbirths. Ma'am, would you like to add anything? Rama,
I think we have covered everything. If the panelists would like to add anything. Patel sir, would you like to guide us on any additional points to be considered?
Okay, I think we can end the panel. Thank you all for being a part of this preventing stillbirth opportunity. Yes, and thank you for giving us an opportunity to be a part of this panel. Thank you.
Thank you.
Thank you, ma'am. That was
Thank you, MC
excellent
Patel, sir,
panel.
and the team. Thank you.
Thank you, ma'am. Moderators, that was an excellent panel. I would request any of the panelists, would they like to give one-liners, and then we can close the session, ma'am. Vote of thanks, and we can close the session. Dr. Shatabdi, I think.
Yes, ma'am. That was a very, very good panel discussion, actually. One-to-one questions and take-home messages. Thank you, Neelam ma'am, Sridevi ma'am, for the very, very nice panel discussion. I would take this opportunity to thank all of you for being there, all our speakers, our chairpersons, my co-coordinators, and the moderators, the expert panelists, as well as the panelists for a very, very engaging academic session. We would take this opportunity to request all of you to kindly vote and support MC Patel sir for the upcoming elections. This series of webinars are the brainchild of his. So let's all try and support him as much as possible. Last but not the least, thank you, Corona Remedies, for providing us the platform for having this excellent academic discussion. Good night, all of you. We'll see you all soon again.
Thank you. Good night.
Hello.
Yes, sir.
Sir,
shall I close?
Oh, yes. But before
Okay,
you
sir.
close, big round of applause for learned moderator for moderating very nicely this panel.
Thank you so much, sir. Thank you so much.
And for all the panelists who have put their inputs to make this panel very interesting. And thank you, Corona people, also for educational support all the time. Thank you, and we can conclude.
Yes. Thank you so much, sir. Have a good day.